develop AfroPHC as the voice of the primary care and primary healthcare team in Africa. And we do this by sharing resources, supporting each other in building the primary healthcare team for UHC in Africa. We have about diversity of about 635 members from about 64 countries. And we do this by sharing resources. We also have elected board members who are very keen to advocate for primary healthcare and universal health coverage. So I want to welcome you to this workshop today. And our main aim of this workshop is to explore the role of pharmacists in primary healthcare and to also see how we can integrate and improve the pharmacy services at the primary healthcare level so that we can support UHC in Africa. So we have three main objectives today. One is to define the role and value of the pharmacist at the primary healthcare level, to explore the models of integration of pharmacy services into primary healthcare in Africa, and to explore ways to improve pharmacy access and services at the primary healthcare level in order to support universal health coverage in Africa. So welcome to our discussion today. We will have 4 speakers, after which we'll have a question and answer session where you will get to engage with the speakers and have a discussion around their presentations and any other questions that may arise during the presentations. So please feel free to put your questions in the chat, or during the question and answer session, we'll have you raise your hand and you can ask your question. After that, as is customary of the AfroPHC policy workshop, we will break into groups for about 45 minutes and have a round of discussions in our smaller groups, then present whatever we have discussed in plenary before we close the workshop. So that's just a little bit about how the workshop will flow. So to start us off today and answering the question, how best can pharmacy services be integrated and improved at the primary healthcare level to support UHC in Africa? Our first speaker today is Dr. Nseabasi Emmanuel Ekanem, who is a 33-year-old Nigerian pharmacist who is passionate about expanding the roles of pharmacists at the primary healthcare level. Ekanem is the current secretary of the Vaccine Monitoring and Evaluation Committee in charge of the COVID-19 vaccine rollout across community pharmacies in Nigeria. He is also undertaking a Master of Science degree in Public Health at the University of Lagos in Nigeria. He is the founder of Trinity Healthcare Foundation, an award-winning nonprofit organization working to strengthen access to healthcare delivery for the most vulnerable in Nigeria. He has also consulted for several other organizations towards the delivery of a number of global health projects in areas such as viral hepatitis, HIV, malaria, family planning, nutrition, specifically vitamin A supplementation, and neglected tropical diseases. Ekanem loves reading, traveling, and watching movies at leisure times. And now, over to you, Ekanem.
Good afternoon, and thank you very much for having me. I hope I'm audible enough.
Yes, you are.
Can you confirm if I'm... okay, great. Thank you very much for the opportunity. Yeah, for the opportunity to speak today. Today, I want to speak on strengthening the involvement of community pharmacists, or rather pharmacists as a whole, in the delivery of immunization services in Africa as a whole, towards infectious disease prevention. And we're looking at some of the opportunities and then the challenges that we have in this regard. And I don't know if my presentation is available there. I'd probably love to start the presentation. Can we pull up the presentation so I can begin? Okay. Okay, great. Thank you very much. So, so today we want to talk about, I want to talk about strengthening the involvement of pharmacists in the provision of immunization services for infectious disease control, the challenges and the opportunity. And this is very, very, very necessary. It's quite timely at this time when we are battling with COVID-19, which is ravaging every part of the world. Just recently, we are hearing that the Omicron variant is surging again in China and other parts of the Southeast Asia. And of course, this reinforces the need for us to look at ways in which pharmacists can actually key in and strengthen the delivery of immunization services to the people. So today I'll be looking at this topic under the following outline. I'll do an introduction. I'll look at pharmacists and immunization. I'll look at the gaps and opportunities for involvement of pharmacists. I'll look at the reason why pharmacists must be involved. I'll look at the challenges and some of the limitations, and then of course, the opportunities and policy advocacy, and then I'll conclude. Let me begin by saying that Nigeria, as well as African countries and low and middle income countries, are far behind when it comes to immunization coverage. I mean, year after year, the United Nations Children Fund, that's UNICEF, often conduct what we call the multi-indicator cluster survey to assess immunization coverage across different countries. And oftentimes we see that in Africa, the numbers are always pretty low. And the question is that often beckons is what are the factors responsible for this, and how can we close the gaps? Because we are all looking at universal health coverage by the year 2030. And for that reason, we are looking at how we can ensure that every newborn, every infant in Africa has access to immunization. The COVID-19 perhaps has further, drawn us further down. The effort that we made over the past 10, 20 years was actually had plummeted in 2020 and 2021. And of course, the reason for that is quite obvious. We had a lot of, infants that could not take their routine immunization during the COVID-19 lockdown, which really affected the number. Now, up to 35.1% of infants born in sub-Saharan Africa have not completed their vaccination. This is a study carried out by Andrew and the team. And it's so worrisome to know that in Africa, we have up to 10% of infants that have never even received a single shot of vaccine. That's really bad. And of course, that can be explained, or that can explain why we are having a lot of childhood vaccine preventable diseases like, pneumonia, we have cholera, we have measles, we have diarrhea, and the rest of them. It's quite common in sub-Saharan Africa. And of course, that is not unconnected to the fact that we're having very low immunization uptake in Africa. Now, poor access to health facilities, low manpower, inequality, and poor maternal health seeking behaviors have been found to be some of those contributing factors why the uptake of immunization in sub-Saharan Africa is pretty low. If you look at the next slide that we have, you look at the graph there that shows us, the uptake of immunization, childhood immunization across different regions, vis-a-vis the burden of, vaccine preventable diseases. And you see that sub-Saharan Africa is topping the chart, which is not good at all. And this, what we want to achieve by bringing pharmacists into, the ecosystem, the immunization ecosystem, is to see how we can close these gaps, how we can increase the coverage by providing more access, by bringing more, resources or more providers into the service provision for immunization. And so we say that the role of pharmacists in providing primary health care has been limited over the decades. Please, can we go to the next slide? That's where I am right now. So over the years, over the decades, pharmacists have been tied to just dispensing medications. As a matter of fact, you hear people often say, pharmacy, you either go to a pharmacy or they call it dispensary. And once they call it dispensary, the impression that people have, the public has, is that just the only thing that pharmacists do is just to dispense medication. But we know that pharmacists do much more than that. By virtue of training, by virtue of the service provided to the community, pharmacists do more than that. The good thing is that COVID-19, the pandemic that we are currently battling with, has brought to bay the critical roles of pharmacists in providing primary health care. I'm sure that many of us know that during the COVID lockdown in so many countries, not just in Africa, we saw pharmacists stepping in to take charge because a number of persons could not go to the hospital anymore. Hospitals were now seen as the hotspots where COVID-19 can be transmitted as a nosocomial infection. And so because of that, more people had to fall back to the pharmacy. And the pharmacists actually stood tall in ensuring that they deliver primary healthcare services to people. And honestly speaking, pharmacists did so well, not just in Africa, but in the US. I remember one of the comments made by the president of the US, Joe Biden. He said that the pharmacists have done so much. And because of that, the president himself said that over 40% of Americans got their vaccine, their COVID shots at community pharmacy. Can somebody still say that community pharmacies pharmacies are merely dispensers? No, pharmacists in the US actually provided vaccine for over 40% of the American population. In Nigeria, even though it started lately, in Nigeria, it was late. Primary Healthcare Development Agency had to bring in pharmacists, into the service provision channel for COVID vaccine. And we have seen some efforts, some progress made in that regard. Unfortunately, this progress have not been documented, which is one of the reasons why, one of the things we should discuss at this workshop, how pharmacists can improve documentation, data capture, because it is a data capture that pharmacists or the data generated by pharmacists that can be used to support advocacy efforts. Honestly, we need to look at this in the course of this workshop. Now, if you look at the next slide, you see that impending problem. In fact, there is a problem right now. And the challenge that we have in Africa is that the health worker to patient ratio is too yawning. It's too yawning. You can see the numbers there across different countries in Africa. This is just a summary from a few countries in Africa. In some countries, it's even worse than this. You can see that in some countries, we have less than one healthcare worker to 1,000 patients, 1,000 of the population. And because of this, there is need for us to apply the policy or the principle of task shifting, task sharing, which we are going to discuss further in the course of this presentation. But the truth that stays us in the first is that more healthcare workers from Africa are migrating to North America and to the UK for greener pastures, leaving the African population with little or no attention, or fewer healthcare workers to attend to the healthcare needs of the people. Now, so that is why we're saying that pharmacists must be involved. We need to bring pharmacists into, the service provision, the ecosystem of immunization in Africa, in the entire Africa, given the reality on ground. And of course, the fact that the birth rate in Africa, as we know, is increasing. If you look at the population pyramid in Africa, you'd see that the older population is perhaps very, very slim, whereas the base where the younger population is very, very large. Africa has a relatively large young population. The population of, the birth rate in Africa is increasing. Unfortunately, it is not compensated with immunization service delivery facility or personnel. And so that is why we need to make sure that we bring in other providers to help, in supplementing this effort. And of course, even the fewer healthcare workers that we have are already overwhelmed, managing COVID-19, Lassa fever, cholera, and yellow fever. In Nigeria and in many other countries, beside the COVID-19, even in some countries in Africa, Ebola has resurfaced. There's a surge in Ebola cases. Now, this limited number of healthcare workers are still involved in this. That means we need to bring in more providers. And good enough pharmacists are trained to deliver primary healthcare services, particularly those who have gone for continuous professional development courses. These people have received enough training to provide the services. So in the next slide, you'll see a pharmacy-based immunization. I took this picture from Julie Pharmacy that is practicing pharmacy-based immunization. And these professionals, these very good-looking professionals that you're seeing, are doing an incredible job in making sure that people receive their immunization. Both childhood immunization and adult immunization is administered at this pharmacy. It's a very beautiful site somewhere in Lagos, Nigeria. So in continuation, for us to achieve optimum coverage of universal birth dose vaccine, it requires a multidisciplinary approach. Unfortunately, one of the problems we have in Africa is that there is no cohesion, there's no collaboration among healthcare workers. Everybody wants to operate on his or her own. We cannot achieve universal health coverage that way. We need to come together. We need to have that handshake for us to achieve meaningful progress in that regard. Community pharmacists are the most accessible healthcare workers. This one cannot be overemphasized. A number of research, a number of studies have been done in the past, and it points out to the fact that community pharmacists are the most accessible. Community pharmacists are highly ubiquitous. I'm sorry, I'm using the word community pharmacists here because when we look at primary healthcare services, our focus is basically on what community pharmacists can do at the community level. And that's why I keep mentioning community pharmacy, but it is used here generically. It involves both those in the community and even those in the hospital setting. Now, pharmacies are highly ubiquitous. They're everywhere. Almost all the districts across Africa, we have pharmacies there. Even satellite pharmacy facilities, we have them there. Pharmacy operate for extended hours. So an average pharmacy works for between 8 a.m. in the morning till around 9 p.m. or 10 p.m. So even nursing mothers who are working class, after they are done with their day's work, they can still go to the pharmacy and receive receive immunization for their infants. And so that is where community pharmacy close the gap, because most public health facilities, most public immunization clinics have very, very limited operation hours. Pharmacy-based immunization does not require, appointments or bureaucracy. For example, in the pharmacy I just showed you, that Julie Pharmacy, you can walk in there and then get your shots. Whereas in most immunization clinics, you have to schedule an appointment. Sometimes you go and the appointment is canceled. Like what we saw during the COVID-19, during the heat of the COVID-19 pandemic, a lot of appointments were canceled. Now, if you look at the next slide, you see a picture of a crowded and overcrowded health facility, immunization clinic. And on the other side, you see one of the pharmacies in the US, Total Pharmacy, that is doing immunization service. You see, when these healthcare facilities are crowded, transmission of airborne diseases is very, very rampant. And so we are saying that instead of us to expose our nursing mothers to the risk of contacting communicable diseases, why don't they walk into community pharmacies and pick up their immunization? And that's why we say that community pharmacies are the first point of contact. We all know this for members of the community that are seeking health care services. And, the fact that most, immunization clinics are overcrowded. In 2020, I supervised the project, the MAP project, funded by the United Kingdom through the Fleming Fund. And when I went to some facilities, honestly, the site was left a lot to be desired. You need to see the way nursing mothers were almost falling over themselves in the healthcare facility. And I was just wondering how much COVID-19 must have been transmitted in those facilities. Why don't we decentralize these services. Let people go to different facilities. And I'll give you a very quick example here. Before now, ARVs, antiretroviral medication, were always dispensed in the hospitals. And I'll tell you that a lot of people could not go to the facility because of the crowd and the bureaucracy, the drudge and all of that. But when we brought in community pharmacists to start administering, to start dispensing, to start refilling ARVs, a lot of people prefer to go to the pharmacy than to go to the hospital to get their ARVs. So it cannot be overemphasized the importance of community pharmacy or pharmacy as a whole in providing primary healthcare services such as immunization. And another advantage is that community pharmacy already have pre-existing cold chain storage system. So if you're talking about storage of vaccines, which are cold chain products, then community pharmacy come in really handy because they have fridges. They also deal with other cold chain products like insulin. So community pharmacy can actually keep this vaccine and administer it to the patient. And of course, even in cases of mild to moderate, vaccine adverse reaction, there are anti-allergy medication already stocked in the pharmacy. What a wonderful place for immunization to be carried out. But in all of this, there are limitations, there are challenges. Why pharmacists are not able to play a very critical role, despite the opportunities, despite all the advantages that I've just listed out. The reason why pharmacists have not really been able to do their work with regards to immunization is because of the following reason. Number one, unfavorable policies and practice environment. A lot of policies are limiting pharmacists from providing immunization. In fact, I know the battle that we had to go through in Nigeria. I was part of the team that engaged the National Primary Healthcare Development Agency so that pharmacists can be allowed to provide COVID vaccine. It was a very big tussle. So the policies are not favorable. And I believe that at the end of this workshop, we'll be able to come up with a communique that we can use to engage takers on how pharmacists can be allowed. The policy can be reviewed so that pharmacists can be allowed to provide immunization services. Lack of cooperation among healthcare workers. I said this before. Doctors want to do everything on their own. Nurses don't believe that others should be involved in immunization. This is not the way we should operate. Everybody, the entire healthcare team should work together. The goal is to make sure that the health and the well-being of the patient or the client is maintained. And so everybody must cooperate. And there is where tax shifting, tax sharing policy must come in to play. Some roles that were maybe carried out by nurses before, we can share some of those roles. We can shift them to community pharmacists. Some roles carried out by doctors before, primary care roles in particular, can be shifted to nurses. Nurses can be trained to do that. Pharmacists can be trained to carry out, so that way we can maximize or optimize the few healthcare workers that we have within the African continent. And then, of course, lack of interest. In a continuous professional development program is among pharmacists, one of the challenges. Many pharmacists don't want to, don't want to take up professional development courses, especially in the aspect of primary healthcare services like family planning, immunization. And that is why one of the things that we should be able to come up at the end of this workshop should be ways we can encourage pharmacists to go for these courses so that they can improve their capacity and their skills in providing these services. Poor documentation, I said this before. We need to, as pharmacists, we need to document all our interventions. I'll tell you something. During the COVID pandemic, I practically visited some pharmacies. I saw what community pharmacists were doing. They were doing a lot of intervention, but unfortunately, there was no documentation. And so when we want to go for advocacy, to tell the policymakers what pharmacists are doing and the need for them to be integrated fully, we don't have documents, we don't have data to show. That's why pharmacists must improve documentation. Low public awareness. A lot of people in the society feel that pharmacists are just dispensers, like I said before. We need to correct that impression through advocacy, through public awareness. And then, of course, intra-professional strife within the pharmacy profession itself. You see a lot of pharmacists say, no, we shouldn't do it. Some say we shouldn't. That has to stop. We need to work together so that we can deliver, the services that people need towards universal health coverage. Now, if you look at the next slide, you see the training that we did in Nigeria. I facilitated the training of community pharmacists, in vaccine administration and delivery. And this was the training done before the rollout of COVID-19 vaccination across pharmacy. And you see, some of the people that came there that were trained are doing incredibly well in providing these services to the teeming Nigerian population. This can be propagated across the length and breadth of Africa. We can train pharmacists as immunizers so that they will help us to close the gaps in terms of immunization delivery. With regards to personnel, it's very important. In all of this, let's look at the opportunities and policy advocacy. What are the opportunities? What can we leverage on? Now, first of all, we need to engage policymakers on the tax shifting and tax sharing strategies. Like I explained before, we can share some task, all right? No task in the primary healthcare level is a cast on stone. We can share, we can improve the capacity of other healthcare workers to provide these services. We have thousands of community pharmacies across the length and breadth of Africa. Just imagine that we bring those people into the mainstream of immunization service delivery in Africa. We would be able to offset and augment the number of healthcare workers providing immunization. And that is one of the fastest ways we can achieve immunization coverage. Because I'll tell you something. One of the reasons why you see me emphasizing personnel is that if you go to some of these primary healthcare centers, it's not as if the vaccines are not available. Yes, they are available. But you see about 500 nursing mothers with their infants, and you see 2 people attending to them. Some nursing mothers may have to stay from morning till night before they have access. Some have to even bribe healthcare workers so that they can have access. If we decentralize this by through tax shifting and tax sharing policy, some people can go to the community pharmacy and have their immunization. Some will stay in the healthcare facility. That way, we will have efficiency, we'll build more efficiency in the system. 2, adoption of a multidisciplinary and multi-sectoral approach to primary healthcare delivery. We need to bring all the disciplines together. All the sector, it has to be a multi-sectoral approach. Every hand must be on deck in this regard. We need to strengthen pharmacists' capacity by delivering immunization services through CPD programs, like I said, continuous professional development programs, and interagency knowledge sharing. I'll explain this interagency knowledge sharing. During the COVID, rollout of COVID vaccine in community pharmacy in Nigeria, one of the things we did is that we brought in the National Primary Healthcare Development Agency. We told them that, look, why don't you people come in and train our pharmacists, train them to provide these services? And as I speak to you in Nigeria, a number of states are already trained, pharmacists in a number of states in Nigeria are already trained by the Primary Healthcare Development Agency to administer vaccine. This approach has worked so well and is helping a lot, in increasing the critical mass of providers of immunization services in Nigeria. We can do this across the length and breadth of Africa. We need to improve the documentation. This is very key because as advocates, for us to be able to push some policies, we can only do that if primary healthcare, if we are able to document the primary healthcare services that we are providing. For example, I give us a very quick example. In Nigeria today, 2 states in Nigeria implemented the Bill and Melinda Gates Foundation funded Integrate E project, which had to do with delivering of family planning services, modern contraceptive method through community pharmacies in Nigeria. And I will tell you something. In those 2 states where this project has been implemented, the contraceptive prevalence rates in those states have increased between 2017 and 2021. That means the community pharmacists have been able to do so well in providing family planning services. We can also achieve that in immunization, and not just in Nigeria, but throughout the length and breadth of Africa. We need to strengthen public and professional awareness of pharmacists. It is very important. The public must know what we can do. And even among professions, we need to know what we can do. And in the next slide, you see some of my speaking engagement. One of the things I do is that I visit media channels, most of the media channels in Nigeria and beyond, to talk about how we can bring in pharmacists, how we can improve the healthcare delivery system. As I speak to you, immediately after this lecture, immediately after this workshop, I'm going to be on one of the TV stations to also talk about this. So we need to engage policymakers. We need to do a lot of media engagement to improve the perception of the public and other professionals about what pharmacists can do with regards to primary healthcare delivery. In conclusion, I would say that pharmacists are very critical in achieving universal birth dose immunization coverage in Africa and beyond. They are very critical. And I make bold to say, I'm not a prophet of doom, but I would say that there's almost no way we can achieve universal health coverage in Africa without involving community pharmacy, without involving pharmacists in provision of primary healthcare services. I doubt if we are going to achieve that. I mean, given the volume of healthcare workers we have in Africa, in the continent, pharmacists, particularly those working in the community, must be fully recognized. In so many countries in Africa, pharmacists are still limited. They're not being recognized. We need to make sure that we work with policymakers to make sure that pharmacists are duly recognized as primary healthcare providers. And that way they will be able to provide these services without fear of, authorities and regulatory agencies. All policies and regulatory barriers to pharmacists' involvement in immunization must be adequately addressed. And I guess one of the things that we are going to get at the end of this workshop is we probably should be able to develop a document that we can present with the policymaker and say, look, we need to address these barriers. Every barrier that is making pharmacists not to be able to provide immunization service, that has to be adequately addressed. Involvement of pharmacists in delivering routine immunization in Africa will remarkably, and I'm putting this very, very vehemently, will remarkably improve service efficiency and access, because those are the two things that determine, the uptake of immunization: access first, and second, efficiency. Thus, putting us Africans on track towards universal immunization coverage by the year 2030. Thank you very much for your time. I really appreciate it. Vaccination, like I say, saves lives, and pharmacists must be involved. Thank you. Over. Hello?
Mercy, you're on mute.
Sorry, Mercy, I mean, Mary, yeah. Mercy, I think I've allowed you to now unmute. Sorry.
All right, thank you. Yes, thank you so much, Dr. Emmanuel Ekanem. Let's give him a round of applause for that wonderful presentation. I think most of us, it's true, we look at pharmacists as just dispensers, but there's so much more they can do. And still going further into this discussion, I would like to introduce Dr. David Odhiambo, who is going to look at how do you model the integration of pharmacists in primary healthcare towards the realization of SDG 3. So Dr. David Odhiambo is a pharmacist with a passion and commitment to improving access to quality healthcare and also nurturing socially responsible generation through his vocation. He is a regulatory affairs associate with Novartis, and he's based in Kenya. He doubles up as a co-founder of Culture Health and Social Innovation, and a social enterprise which is committed to improving access to quality healthcare services and promoting human capital development in Africa. And he's also the curator of African Pharmaceutical Network, that is APN, which is an initiative working to mobilize pharmaceutical industry players in Africa for knowledge sharing, policy sharing, and innovation, and nurturing discussions in efforts to improve access to quality, safe, and efficacious healthcare products and services for the African populace. During his free time, David loves to read, blog, and entertain friends. Over to you, David. Welcome.
Thank you so much, Mercy, and thank you everyone for this opportunity To the AfroPHC team, it's a pleasure to be part of the discussion and to engage as we share insights on what we believe, or probably what we know has to be the role of the pharmacist, and to look at what mechanisms are there for us to bring pharmacists to the fore. And beyond bringing pharmacists to the fore, is the key is how do we deliver on our aspiration of ensuring that we realize the SDG number 3, that is good health and well-being for all. And on that account, the key bit would be taking and in using every single resource that is available within our spaces and making the best use of them. So on this account, my presentation today will be around modeling the integration of pharmacists in primary healthcare towards the realization of SDG 3. And as I go through the presentation, I know my colleague, actually, Manuel, has presented a case for immunization that is a very critical bit when we look at this. But as we go beyond the immunization component, what we need to ask ourselves from my perspective, based on the work that I do and my passion and interest in pharmacy, the key is everything is about social behavior change communication and making it be a part of our programs and part of the system that we're looking at advancing progress in our communities. When you talk about family medicine, we are looking at people before they even become ill. That is at the healthy phase. Can we keep them healthy as much as possible? What are the infection prevention mechanisms that we're adopting? Disease prevention. What are the health promotion activities that we are promoting within the individuals? And in case they fall ill, what are the curative measures that we are championing for and that we are making accessible to the communities and individuals to make them be able to attain the positive health outcome that we wish for each and every individual? And ultimately, we'll move into the palliative and the curative, the palliative and the rehabilitative aspect, depending on which space in the continuum of healthcare services and the healthcare spectrum is this person as an individual and as a patient that needs healthcare services and healthcare provisions. So in this case, when I look at it from the dimension of what does primary healthcare entail? So it's the whole of society approach. Everybody has a role to play. And the key is to ensure that we all attain the highest possible level of health and well-being through equitable distribution by focusing on people's needs as early as possible. And that is what covers the continuum of care services that we're talking about. And in this case, we look at it from healthcare services that they need, the intervention. Let's say, for example, the physicians in the room, you'd be dealing with surgeries, operative procedures for an individual. Other than that, we are looking at the use of medicines, who ensure the medicines are available, the pharmaceutical supply chain optimization and related. Then we look at the additional procedure, for example, an injection, who is injecting the patients? Most of the times we have nurses coordinating such functions. Then ultimately, how do we ensure that the best outcomes are being achieved? That is where we now look at the additional role for the pharmacist. Now that's where the pharmaceutical care comes in. Medicines reconciliation, medication therapy monitoring. How do we integrate into such system and ensure that at the end of the day, the patient realizes the positive outcomes that we all wish for? And those are the key things that we need to look at from that dimension. Then when we look at it in terms of the presentation that I had from Emmanuel, one thing that I want to make clear for all of us to understand is that pharmacists will practice across different settings. There's the one that is in the community pharmacy setting. And I know most of the times when we talk about pharmacists in primary healthcare, that is where we think of pharmacists. The person running a pharmacy store, a drugstore next to your neighborhood. Yes, there are some who are pharmacists, some are pharmaceutical technicians, technologists and related, but with a pharmacy background. That is the first phase. Another phase where we have pharmacists, we have different programs that are being run by different organizations across the world. NGOs are related. These interventions that are delivering from primary healthcare services to the communities. What are the roles of the pharmacists in such kind of setups? What are some interventions that they can deliver? Then we go to the public health system from hospitals at primary care levels and related. Most of the time, for example, using the case of Kenya, pharmacists would be found at level 3 hospital, that is the primary health centers. Then we move upward, and most of it's managerial position. So what are their roles in such spaces that ensure that primary healthcare, our aspirations in ensuring everybody has access to the primary healthcare services they need are being realized? That would be looking at, are they optimizing the supply chain to ensure medicines are not available? Because some of the times we're working in these institutions, but the most actually dispensed product in these pharmacies is out of stock. So you just indicate out of stock. Yes, you're serving 1,000 patients or 100 patients going through the pharmacy, but the most critical word that you tell them is out of stock. So what is the pharmacist at the higher level doing to ensure that the supplies are available? So those are some of the things that we need to look at. And as we look at that, we look at the other bit in terms of pharmacovigilance, pharmacoepidemiology. At the end of the day, if I'm using a medicine or a healthcare product, it needs to be safe for my use. And at the same time, in case there's any adverse event that is being realized, I should be able to get somebody to intervene on my behalf. what are pharmacists doing in terms of pharmacovigilance? And so I remember Emmanuel's presentation of vaccines. We have adverse events that are being noted. Who is reporting them? And who is dedicated to follow up on that in the different areas where we work? So, and then we look at it from a higher level, at the policy level. County pharmacies, let's say we have the ministers of health and related. If we have a technical advisor, or even the CS or the minister at all, who is a pharmacist, the key bit is that is a policy level. And our role cuts from the delivery of healthcare interventions, from health education, promotion, up to the point where we are forming policies and advising intervention makers, from development partners to business stakeholders, to deliver these solutions. And if we look at this from that dimension, then we are looking at delivering the intervention that we are hoping for. And that is, those are the scope of the things that I'm mentioning here: health education and awareness creation, access to health products and technologies, pharmaceutical care, that is medication therapy monitoring, medicines reconciliation, adherence counseling and health programs management. Then we have pharmacovigilance, and referral is a critical bit. When you look at the patient journey naturally, oftentimes in our resource constrained settings, when I'm unwell, probably I'm feeling some headache or kind of, I'll go to a pharmacy, buy painkillers or even just management of the symptoms. Symptoms persist, I go back to the pharmacy again. By the way, the medicines you gave me last time did not help me get relief. And therefore, is there an alternative? Then at that point, probably you're giving the pharmacist or the pharmacy technician more information. They'll sell you some other medicine or medical product, which you'll go use. If you get relief, well and good. If you don't, that is where now you consider going to a hospital to seek healthcare services. Reason, the convenience of pharmacies being near to you when you talk about community pharmacies where they are. Then when you go to the hospital, at the end of the day, the prescriptions, the investigations are done, diagnostic procedures and related, a diagnosis is made. After the diagnosis, a prescription is generated. With that prescription, you have to go back to the pharmacy. So that is the whole continuum of what we are looking at. Where do we have pharmacies playing a role? And in every area that they play a role, they can deliver these interventions, from health education, awareness creation, providing medical services, the pharmaceutical care component that we're looking at, and ensuring that we are able to deliver on these. And being mentioned that in this session, I'm about the modeling of the integration of pharmacy in primary healthcare, then the question we need to be asking ourselves is, how do we make pharmacies be part of the primary healthcare teams and to be able to deliver on our primary healthcare aspirations as a community? So when we look at these, they have to be integrated position within the healthcare chain to deliver this. And some of the things that I know, over time, we've all had discussions, let's say, for example, within the pharmacy space, and even other policy discussion forums on the role of a pharmacist, what a pharmacist can deliver. And there are even publications and reports that are actually contributing to this. But the only problem that we also acknowledge that we have is, we talk about what we can do, but at the end of the day, where we do it, we don't document it. And some of the times we talk about it without actually doing what we need to be doing in these areas. Probably it could be because of the interprofessional strife and related challenges, lack of the skills that are required for us to be able to deliver on these services. And based on this behavioral change matrix that I mentioned, lack of awareness that we can actually deliver such interventions. So then how do we ensure that it's happening? When you go to a government institution, there's always a service charter on what they are able to do and what they are offering in that institutions. And it's not only in the government institutions, even within the organization we run. We have an organizational profile that outlines what kind of interventions we're doing. When we talk about AfroPHC, what do you do? Who are the members? Who are the stakeholders? And what services are you offering to your clientele? And in this case, when we're talking about such kind of a model is, as a pharmacist, depending on the environment where I'm practicing, what interventions am I delivering to the people? What services am I offering? Then the key is to ensure that we establish a service charter. And in the next slide, I'll be talking about how do we come up with a service charter, so that at the end of the day, when we talk about pharmacists delivering services in primary healthcare level, then we know what does it entail. If we're talking about vaccination, what vaccination programs are they delivering? And why is it that some of them are not doing it at the same time? Because the other things that we forget about is there are drivers for people to practice, and there are the disincentives to practice. If a government institution is offering the immunization services, it would be good, yes, that is the normal standard procedure within the public health institutions. But where they're not able to reach the communities, we have primary care pharmacies, the community pharmacies that are available and accessible to the communities. How do we integrate community pharmacies to be partners to the government institutions and the government framework? so that they're able to deliver? Who is going to offer remuneration for this? Who is tracking these kind of deliveries? And I remember in 2018, when I was doing my attachment, article level 5 in Kenya, one of the key things that I kept asking myself at the maternal and child clinics, they're offering vaccination services, yes, which is good, but in these vaccination programs that you deliver, what happens when a patient doesn't come back? When a mother doesn't bring their child back, how do you know whether they've been vaccinated at some other location? What is our tracking mechanism to ensure that we follow through? And in case that doesn't happen, how do we integrate other people in the local community that can deliver? And such a thing that we need to be thinking about. We might not be able to deliver, but we can structure how such interventions can be done. So once we have a service charter that outlines, based on the disease patterns, for example, if you are in a diabetes endemic zone, non-communicable disease, or an infectious disease zone, let's say, for example, in the Kenya, we have the Lake region predisposed to malaria, then it means as a pharmacy service provider, you should be able to have a malaria management program that is able to, one, diagnose, and other than diagnosis, you are able to offer the therapy, that is the drugs that are used for management. In case some of the children, for example, when we talk about the mortality rate for children with malaria is high for children less than 5 years, it means in such cases, there are high likelihood that there will be complications. Do you have a referral system for such kind of a case? In the service charter, you know, where do I refer? You have even an established engagement with other higher level healthcare institutions so that you can refer them to those institutions when they need specialized care. When you're dealing with neglected tropical disease, for example, leishmaniasis and related, do you have vector control, environmental protection measures? Are you part of the community delivering such solutions? That would come into that. Then once you've established a service charter, knowing what are the things that I need to high priority areas that I need to intervene in, you have that in place. Now you move to the next phase. If I'm going to offer psychosocial support for patients with mental health services, with a high, considering I'm in a locality where there's a higher burden of mental health disorders and distress, then I need to have the skills and the capabilities to be able to deliver on these. On that account, then capacity building and upskilling of pharmacists to deliver on the services as outlined in the service charter comes into place. Because you're not just building, actually training them to get skills. And that is one thing that I acknowledge based on a comment that I saw in the chat. We need retraining or a review of the curriculum. A review of the curriculum would be good if we know what interventions or what the conditions these pharmacists are delivering. And that is now where the service charter is informing our training and capacity building programs. Then we look at the community engagement. If primary healthcare is a whole of society approach, and if it's a whole of a society approach, then we have to all engage with the people within the communities where we're operating to ensure we are supporting them. There's no way I'm going to talk about the risk of tobacco smoking as a contributor to cancer. And next to my shop, I have my actually next door shop is selling tobacco, and nobody's ever engaging them on the impacts of such kind of sales. And maybe somebody in the community is actually planting tobacco as a plant, cash crop for them. So how am I engaging the community to be able to deliver on the services? When you look at it from the healthcare component of delivering healthcare services, we can talk about health promotion. Normally, for example, in my community, I have a couple of friends that we normally go for runs and related. If you're part of the community, you look at it as health promotion. Can we go have, like, let's say weekly a physical activity exercise that will keep us fit? You become a part of the community and deliver interventions that's supporting them to be able to achieve their healthcare needs. Then ultimately, as we do all these, evidence generation and advancement of science. There's no way we are going to talk about what the contribution of a pharmacist is, or not only pharmacy, even any other healthcare practitioner, in advancing access to quality healthcare services without evidence of what we are doing. In 2020, we had the World Pharmacist Day, 25th September 2020. And the theme for that day was Pharmacists Transforming Global Health. A good topic, yes. And it was coming at a point when we are all suffering from the catastrophic impacts and the effects of COVID-19. Yes, so we need to address global health, and we have a role to play as pharmacists. But the question that I was asking myself, most of the global health challenges are endemic and actually domiciled within the African continent. And as that is the case, what is the evidence of what pharmacists are doing in Africa? If you went online to any resource, could you point out this is the contribution, this is how pharmacists are transforming global health in Africa? We are not generating that evidence. And therefore, however much we can engage in policy leadership, advocacy, and every other political forum where we are looking at getting the buy-in of other stakeholders, it might not work because we don't have a case that is localized and contextualized to our own working model and environment. And that is one thing that we need. Then finally, the second last thing is the financing aspect. Every intervention that is offered, there is a financing component. It is a resource. So what resources are we looking at? The pharmacist who is delivering these services, who is offering the primary healthcare service that we're talking about, how are they being remunerated for the services they offer? Who is paying for such services? That is one thing. Two, the healthcare products. Let's say, for example, when they're offering vaccination, the government would be supplying them here. Somebody is managing the supply. But who is managing the logistics in terms of storage in, let's say it needs cold chain measures, electricity bill, who is financing that aspect? And those are some of the things that we need to look at. And one of the key bits of what I think is an advancement that we can look at as pharmacists and every other person in looking at positioning pharmacists in primary healthcare is, if we see access to healthcare being a challenge because we don't have government facilities closer to people, then imagine if we could position community pharmacies, which are almost in every neighborhood, as primary care facilities. In the Kenyan context with the NHIF capitation, so that I could choose a pharmacy next to my door, next to my house, as my primary care facility. It means that person on a monthly basis, based on the Kenyan rates, will be receiving 200 Kenya shillings. With that 200 Kenya shillings, when I'm having, let's say, for example, headache, I can go to that pharmacy and get paracetamol using my NHIF cover. I have an incentive to be insured by the National Hospital Insurance Fund. But if every time that I have a discomfort, I go to the pharmacy, I have to spend my money, then why do I have to get an insurance by the national government? There's no imperative because maybe I'll never use it. And oftentimes, let's say, for example, for the last 2 years, I've not used my insurance cover. I do pay, yes, but if I had the option of actually getting services from it, even those who are not paying would have a reason to go for that. Then the last bit is in the policy leadership, advocacy, and strategic partnership. We need to get allies and partners who can work with us on that journey. And as we do that, we need high-level leadership commitment to advancing these. And that is where now we look at it from what is the national imperative, the national interest. In the Kenyan context, I could talk about Big Four agenda. In the African landscape, in the pharmaceutical industry, I can talk about, one, we have regulatory harmonization, which is driven by the African Medicines Agency, partners, International Association of Patient Organization, and related. Then we leave that aspect, we can go to the next one, when we're looking about pharmaceutical supply chain. Over COVID period, there was establishment of the African Medicines Supplies Platform, AMSP. That is another agenda. Then we look at the African Medicine Production Plan, Pharmaceutical Manufacturing Plan for Africa. And that is on the backdrop of Africa Continental Free Trade Area. So there's high-level political interest about different agendas. How do we link these to our own interests within the pharmacy landscape and the healthcare landscape at all, and see that we are selling an agenda that is buying into actually helping the political leaders and governance experts to address some of their priorities in terms of investment. So if we do that, we are able to drive that agenda, and we'll be able to have them as allies even at a national level to support our integration into primary healthcare interventions, because they know if a pharmacist is working as a primary care facility, most of the communities or even my electorate will be able to access the healthcare services they need. That is a win for them. So how do we position ourselves, and how do we plug into strategic initiatives that are being driven by such kind of high-level leaders and governance frameworks? And on this particular slide, the main thing was to look at what would be the mechanism of establishing a service charter. The pharmacy service charter would start from the needs assessment. Where am I locating my pharmacy? If I'm locating a pharmacy in my rural community, then I need to understand what are the diseases that are affecting most of these people. When you engage community health workers, the local health facilities and related, you already can map and see what is the data that is available. And you can even look at the National Health Utilization Index metrics. What health services are being utilized by majority of people? Where do they seek them? And how do I address some of the needs in my own community where they might not be able to see them? Then once you do that needs assessment, you come up with a service basket. And that service basket looking at the priority conditions and priority healthcare needs of the community from which you come. Therefore, you now have a portfolio of the services. So out of that, you now have the core services. Pharmacies, normally, the standard operation that everybody knows about a pharmacy, when you hear about pharmacies, medicines. That is a core service, core product that we can deliver as a services. The medicine reconciliation, medication counseling and related, those are key. Then we look at now specialized services. And when you talk about specialized services, we are looking at emerging disease areas. Those are some of the things that I'm going to mention in this next slide. So mental health space, sexual reproductive health, contraceptive, fertility products. Other than the fertility products, do we have specialized skill to offer additional services in that case? Do we have a partnership with the lab so that we can be able to monitor the drug levels of a particular patient upon treatment, or even the different indicators that we are looking at? Then we are able to make an informed decision. So once we integrate the core services and the specialized services into the service basket, we have a service charter. And then those are services in addition to medicines and health products, which is our forte as pharmacists in terms of service delivery. And some of the key things that I want to just highlight as I wrap up this session. Some of the emerging areas that I feel as pharmacists we can deliver value as players in primary healthcare would be one, mental health. When you talk about mental health, just from the depression, stressful conditions, anxiety-related conditions, most of the times because these mental health disorders and distress would present as physical conditions. So probably I'm feeling headache, I'm having GIT discomfort and related. When I go to a pharmacy and try to express my case and actually get some insights from them, if it's a mental health condition, mental illness, or mental disorder, they would be able to do first aid, offer first aid, that is the psychosocial support. If they feel there's need for additional extra support, referral services come into place. And then in case somebody is prescribed for medications, then they'll be able to support them in delivery of the medicines and also advising in medicine use and continued follow-up, because in terms of our delivery model, we talked about community engagement. They are part of that community. In sexual reproductive health and related, contraceptive use, everybody is buying them from pharmacies and related. Yes, they're good to be obtained from the pharmacies, but what additional services can pharmacies deliver? Contraceptive services, that's good. Fertility care products, they're available. Do we offer fertility clinics that are pegged on our delivery of services? Somebody would come and buy, for example, Fertilion or something, a product that is a fertility care product, but who is guiding them on what is the use? Who is helping monitor the actually optimal outcomes out of the use of that product in the community level? Probably they're not there. Then the other bit is in menstrual hygiene and related when we talk about SRHR. Menstrual hygiene is a critical component, and we're saying no lady should be denied the dignity of having access to sanitary towels and sanitary products. But at the same time, this is a reflection that I had over the COVID-19 period. Government of Kenya had a distribution plan for sanitary towels through schools. Over COVID period, schools were closed, and therefore, some of the ladies that were reliant on this kind of services delivered by the government through schools were not able to access them. But in every neighborhood, we have a pharmacy. What if there was a structured public-private partnership where the community pharmacies serve as logistics partners to the government in delivering these sanitary materials? Then it means there would be continued and reliable access to these services and products. But that is not something that is being practiced. So how do we look into such domains? Non-communicable diseases, the diagnostic measures, management, referral and collaborative practice with other stakeholders. So those are emerging areas. Neglected tropical diseases, we can talk about vector control, health communication. I mentioned that earlier already. Then infection prevention and control, infectious diseases, that is IPC, curative care referral services. That is the same looking at the continuum of care and the care services that we need to deliver. Emerging areas, everybody is talking about the beauty industry, yes, and we have skin care, skin conditions. Everybody is looking at using probably a skincare products, or almost all of us used our lotion or a body, I'd say jelly, a petroleum jelly at one point in time. So why did you choose that particular product? And some of us were suffering from skin condition, let's say, for example, acne. Who is offering you those care services? And being within the landscape of services that can be delivered by pharmacies, what if we have a cosmetologist pharmacist who is able to support patients with skincare conditions, including the fungal infections that might be there? That would be a win. Immunization program, that one I'm not even going to talk about because I know Emmanuel did a wonderful job at that. Emergency response and preparedness. We had just the most critical one. COVID-19 happened, yes. What is our response interventions? Currently, we are having the challenges in Russia, Ukraine. There's unrest. With this unrest, the people who are being affected are the local communities. What healthcare services can we support as pharmacists in delivering interventions to the communities? Pharmaceutical supply chain, no need to go into that because that is an area that we all know. There's a need to ensure that we have reliable access to medicines, and those reliable access to medicines, we should be of quality, safety, and efficacy standards that are recommended by the global standards and regulatory measures. On patient safety, every care that is intervention that is delivered to patients, we need to ensure that it's meeting the standards. That is where patient safety comes in. Pharmacovigilance, as I mentioned. And I'm looking at pharmacovigilance not only in the healthcare system, but even from an NGO perspective. I remember last week I had a conversation with a friend, and this is what was coming up. What can a pharmacist offer in an NGO setting or a nonprofit organization that normally does medical outreach programs? The first thing is you need to do assessment of the products to ensure that they're registered in the country where they're being used. Because if they're not registered, then in case of any adverse event, who is going to take responsibility? Who is going to take charge of that? Can you educate patients on how to report any adverse events that are available? Then in case they happen, how do you monitor such? Investigation measures. How do you correct? What are the corrective actions, preventive actions? And who is capable to actually follow through the metrics, if not a pharmacovigilance expert? So those are the aspects that we look at in terms of patient safety, because at the end of the day, the care that we offer patients should not harm them, but should be able to empower them to achieve the best outcome they're hoping for. And self-care. As individuals, we are all keen on having control and self-determination over our lives. And that aspect on autonomy is what we are aspiring for. But the key bit is, how do we then get such kind of control over our own healthcare services without having to be going to be hospitalized or anything? It can be done by having people educators, and pharmacists can offer that education. Pharmacists can offer access and delivery mechanism. For example, now we have some pharmacies that are offering delivery services for medicine that are bought through their platforms. That is an aspect of self-care. So in self-care is about educating patients to be aware of the general public health literacy. Then from the health literacy, ensuring the products that they need are available, and employing the use of digital platforms and digital technologies to ensure that patients can make the best use of the information and the health products and services that you've made accessible to them. Ultimately, as I conclude, for us to be able to achieve all these that we're wishing for, we have to think in a systems way, systems thinking. And then we have to be focused on what intervention are we hoping for. We don't need to be unilaterally and actually confined to a particular area of work, but we need to be broad-minded and thought thinking of what interventions would we need to help every patient or each patient to act as human beings. Rather than treating a disease, you're treating a person. And that is where we talk about the human-centered design. What makes the patient have the best outcomes at a personal level? What meets their needs? Once we're able to deliver on that, by applying a system thinking, knowing that we're not able to deliver everything at our own level, but we need to integrate and work with others, we are able to deliver on our aspiration. And at the end of the day, we would be in a better position to achieve the SDG 3 as we all wish for. Thank you so much.
Thank you so much, David, for that wonderful presentation. In fact, you've covered so much scope that I'm sure a lot of people did not imagine a pharmacist would be able to function in that area or be able to contribute in so many different areas of healthcare. So we're going to take a pause here. And if there's anyone with any burning questions, please raise your hand, and we will take, for the next 5 minutes, we'll take a couple of questions. On the chat, I can see Senkira is asking, how should we ensure self-efficacy among pharmacists? I don't know if Senkira would like to expound a bit more on that. I'm checking to see if there are any raised hands right now. If you have any question on David's presentation or Ekanem's presentation, you can go ahead and raise your hand. I can see 2 hands. Let me see who these are. Sorry, I'm not able to see everyone on my screen. Just a minute. I thought I saw a hand raised.
Is Teresa ready?
Teresa, please unmute. Go ahead. Teresa, are you able to unmute?
You can all unmute yourself now.
Yes, thank you. Now I can unmute myself. Thank you very much.
Go ahead.
Great presentation there. My question is, among the plans, like Daktari has shared lastly about the service charter, the community service charter, which is very, very good. I would want to ask him what plans would be in place to maximize on a multidisciplinary team approach for primary health care. How would pharmacists then work with other players, health care providers at the primary level? Because there's so much space. There's so much into that space where pharmacists have touched on that they can bring in value. But how then do they integrate that in a multidisciplinary team? Thank you.
Should I respond to that, or we
yes,
take others
please
first?
go ahead. Yeah.
Okay, thank you. So thank you, Teresa, for the wonderful question. And I think it's possible for us to work with others. And that is the overall scope of what I'm envisioning with a service charter in place for community pharmacy. When we have a service charter, we know what is the scope of what we can deliver. But we also know clearly what is beyond our scope. And therefore, for example, if I talk about something that I'm passionate about on mental health, I would do first aid for a patient because based on my psychosocial training, basic first aid, right? After that psychosocial support, I would be able to acknowledge that this patient needs additional care. Therefore, I'm able to refer them to a psychotherapist or a neurologist somewhere who would be able to offer specialized care. And therefore, it means in our service charter, even in an organizational level, in terms of structuring your services and interventions, you already know I need to have partners who will be able to help me in these particular areas. If I'm offering mental health services in my pharmacy, then I need to know in mental health services, there's a scope of what I can do. There's a scope of what is beyond my reach. And therefore, for that, I already have structured partnerships with people who can deliver the additional services. That could include a neurologist, a psychiatrist somewhere. Then for the supply, for the medicines, I'll be able to deliver that because at the pharmacy level, I might be having them. For other conditions, let's say, for example, you need to manage somebody with malaria, diagnostics. Are you allowed to offer by law to offer the initial diagnostics? I know the rapid diagnostic kit is allowed, but if anybody needs the, let's say, PCR test and related, you need to have now partnership with lab people to be able to do the diagnostics for you. But after the diagnostics, a clinician or a physician can help make prescribe the medication based on that diagnosis if you're not allowed to prescribe in the jurisdiction where you work. But at the end of the day, you are still within the matrix knowing this is what is within scope for me. These are the services within for the same condition, for the same healthcare need that is beyond me. And therefore, for that, I need others who are able to meet that, to bridge that gap. And that is where, let's say, for example, when I talk about immunization, other pharmacies in a community pharmacy, I could be offering logistics and storage services where they need cold chain. But the community health workers can be taking medicines from me at the pharmacy to vaccinate children in their communities. At the end of the day, they'll come and report back and actually return any remaining doses for future use. That is already integration and collaboration with others. So we need to look at what are we offering and what do we need more to be able to meet the needs of our communities. I hope I've answered you better.
Thank you so much, David. Actually, you've actually answered another question which I've seen in the chat, which was asking how do we ensure cadres and professionals stay within their scope of trained competence, which you have answered quite well in the end with the whole look at the team you're working with. Do what you're doing, and what you cannot do, someone else is able to do, and they should be able to support you in that. I'm going to take Funmilola, then there's someone, I don't know, health and music. You can go after. I think you can rename yourself so that we can know who you are. Funmilola, please go ahead.
Good afternoon. Thank you, David, for your presentation. But I just want to mark some things that is happening in Nigeria in particular. Most of the PHC, they don't even have drug and they don't have human resource. Most of the PHC, they don't even have pharmacy. So I don't really know if there's no drug in PHC, how will the pharmacy function better in the PHC? Am I clear?
Could you please clarify what a PHC is?
She said PHC, primary healthcare.
Oh, okay. Yeah. So functioning better without medicine, that is not a possibility. And that is why when I was starting the presentation, one of the key things that I tried elaborating is the fact that our services are not only limited to medicines, but in whichever area we are, we need to acknowledge there's an intervention that we need to offer. When I was talking about the sub-county pharmacies or a county pharmacies, they are key in terms of ensuring the management of pharmaceutical supply chains are optimal. So there's no optimal management pharmaceutical supply chains when the most used medicine is out of stock. You're not serving any need. And that is where we have a challenge. And I think that comes to the aspect of what kind of needs do we have in our communities? medicines have to be there. So there's no way that you're going to deliver on primary healthcare without medicines. And as you're doing that, then the other bit would be, what are the other innovative mechanisms that you can adopt? Because one of the things we have to acknowledge is we might not be able to change the system and actually get medicines available instantly from the government when we're dealing with primary healthcare centers. But what options are there for you? And I'm going to give a case of some intervention that we designed at Kasarani Health Center in Nairobi, Kenya last year, but one around August, October. I was working at the primary healthcare facility doing my internship, and we noted that we have patients who are diabetic patients, hypertensive patients, who used to come to the facility, but oftentimes we were selling out of stock. So once they've been diagnosed, and actually some of them come with their prescriptions and there are no medicines, we tell them, go buy to the pharmacy next to where you come from. Some of them will tell you, by the way, I'm not going to buy it because I don't have the money now. Or maybe they'll buy half the dose unrelated. So what we ask ourselves is, what other options are there? Based on the work that I was doing with ReCulture in terms of health communication and advocacy, and then the institution and some of the people that I'd met, we had a partnership with Pharmacists Foundation, and we had the partnership with the Kasarani Health Center, that where I was now interning. So being patients will always come to the primary health center to get their care need, to meet their care needs. As an individual, based on the program that I'm doing with ReCulture, I would now reach out to MEDS, Mission for Essential Drug Supplies, and we establish a patient support group. So on a monthly basis, the patients are contributing $5, 500 Kenya shillings. That 500 will ensure their medicines are refilled. So on a monthly basis, they are assured of getting their medication. But this is now a parallel program because they are paying for the medicines and we are sourcing it through the patient support group that is available to them. As we're doing that, we are designing a new model of practice that will ensure they have access to medicines, but also holding the government accountable. Where we have challenges, because there are budgetary allocations for delivery of medicines in these primary health facilities, can you offer additional payments in case we have a shortage? So such kind of interventions need to come in, but we need to look at it from what can we do now and what is the hope? Because maybe the patient support group, it is self-reliant, they are going to take care of their needs, but how is it sustainable beyond ReCulture engaging and supporting it? It is a function of the government. How does the government plug in and support it? So such kind of approaches can help us better. I hope I've answered you.
Thank you so much, David. And in the interest of time, we'll take more questions after the next presenter because she has another meeting. So I'll remember to take your questions and also read your comments after her. So our next speaker is Ms. Tolulope Osigebsan. She has over 10 years of work experience across the public health sector. And she joined the NCD Alliance team in Geneva in 2019 to further develop the NCD Alliance strategy relations with the WHO, United Nations agencies, and member state missions before joining the NCDA, where she worked in both the public and private sectors in Nigeria. Her most recent role was with the Secretariat on the United Nations Interagency Task Force for Non-Communicable Diseases. And she's a pharmacist by training and holds a master's degree in public health from the London School of Hygiene and Tropical Medicine. And she also serves on the board of the African Forum for Primary Healthcare. Welcome, Ms. Tolu, taking us through a case study on NCDs and how pharmacists play a role. Over to you.
Good afternoon, dear colleagues. Good afternoon, the AfroPHC team. Thank you so much for having me. Can I confirm that you can see my slides?
Yes, we can see them.
The proper way, because sometimes it's a bit lopsided. Are they manageable? Are they okay?
I don't know if you can enlarge them or go into slideshow.
Okay.
Because they're a bit small. Yeah.
Is it better?
Yes, that's much better. Thank you.
Wonderful. Thank you so much once again for having me. As Messi has kindly introduced, my name is Tolu. I'm a pharmacist by training, and I currently work with the NCD Alliance in Geneva. And I'm really pleased to be here to talk about the role of pharmacists in PHC using non-communicable conditions as a case study. I apologize for having to, for cutting the Q&A short. I have another meeting at 2, and so I would have to take my leave. So I hope that you find the next few minutes interesting. And just to give a bit of background on what we do at the NCD Alliance. So we're a civil society, we're global in terms of our scope, and we're advocating for a world where people can live free from the preventable suffering, disability, and death from non-communicable conditions. The NCD Alliance was established in 2009 by 4 founding federations, and their names are listed here. But over the past 10, 11, 12 years, we have grown in leaps and bounds to now have 300 member organizations who work across 81 countries. The work we do at the country level and at the regional level is led by our champions that we called the national and regional alliances, and we have up to 66 of them as I speak. But beyond working with our team at the country level, we also have partnerships with different entities. We work with the private sector. We work with obviously the UN, the UN agencies, with WHO, you know, quite well. We work with foundations, with academia, and with several bilateral organizations. And you know, it's been interesting to do this work over the past years to shape a world where people can be free from the scourge of non-communicable conditions. I'm really pleased that we've spent some time earlier in today's presentation to look at primary health care. So I won't waste too much time, you know, on this slide. But basically, when we talk about primary health care, a few things come to mind. Equity, you know, continues to be a key pillar of primary health care. Participation, you know, empowering communities, empowering people to take charge of their care and giving them an enabling role in shaping the health policies that affect them is a key pillar of primary health care. Also, multi-sectoral action, sectoral policy and action is a key pillar of primary health care. And that's also another thing we prioritize within the work we do on NCDs as the NCD Alliance. And you know, when we look at primary health care again, the role of integrated people-centered health services cannot be overemphasized. So these are like the core pillars of primary health care and the things that come to mind when we talk about primary health care and how it impacts on the health of populations. And before I move away from this slide, I would just like to quickly flag that obviously we're all familiar with the development goals that we hope to achieve by 2030. And there's clear evidence that the primary health care is a foundation, not just for universal health coverage, but all the other targets that we hope to achieve, you know, as part of our sustainable development goals. In this next slide, I present to us the NCD Global Action Plan that was launched in 2013. And so basically, member states came together to look at non-communicable conditions and how best to tackle them, you know, over the next few years. And they agreed to 9 global targets. So, you know, there's a target. The first target is to reduce premature mortality by exactly 25%. By 2025. And then if we move on from the first target, we see the target on tobacco use, on alcohol use, on physical activity, looking to promote physical activity, on, you know, tackling salt and sodium intake as part of, you know, trying to manage chronic conditions like hypertension. We also see targets, you know, on raised blood pressure, on diabetes, and finally on access to medicines. So you will agree with me that primary health care will forever be critical to the achievement of these NCD targets, even as we move from 2013 when it was launched towards the expiry of, you know, these targets in 2025. So definitely PHC is a key pillar of the health system response to non-communicable conditions, whether we're talking about developing countries or developed nations. PHC is a critical pillar. And finally, at the base of this slide, I wanted to just mention that obviously COVID has impacted on our ability to achieve many of the global health goals. And so in 2020, member states reflected on the progress on NCDs, you know, from 2013 to 2020, and they decided that there was need to extend these targets from 2025 to 2030. So currently the first target that looks at premature mortality and reducing it by 25% has been updated now to reducing that target by 33%, but by 2030. So and that leads me to the next slide, where we'll see a similar target for, you know, on the UN, by the UN, and that's the very popular SDG target 3.4, which looks at reducing premature mortality from NCDs by 1/3 by 2030. So the WHO's Global Action Plan on NCDs and the NCD target 3.4 are now aligned in what they hope to achieve, in terms of premature mortality. And I think that's very interesting. That helps obviously with reporting processes for stakeholders. Now, apart from reducing that premature mortality, when we look at the SDG target for NCDs, we also see a target on strengthening prevention of substance abuse and the harmful use of alcohol, and reducing the number of global deaths and injuries for road traffic accidents. And the part that interests me most in this target is the means they hope to drive progress, and achieve this, the means through which governments can drive progress and achieve these targets. So the governments are expected to prioritize the work of what we call the WHO Framework Convention on Tobacco Control, to really take strong action on tackling the use of tobacco in communities. Apart from tobacco control, governments are expected to prioritize research and development to promote the uptake of vaccines and medicines and improve access. And I guess, the strongest point for me today in this slide is, the critical role of a well-trained health workforce is acknowledged as one of the key pillars of achieving the UN SDG target 3.4, which relates to non-communicable conditions. And, obviously we're familiar with what makes for a functional health workforce. We have our doctors, we have nurses, we have pharmacists, we have the health assistants, we have the community health workers. It's a wide range of different stakeholders working at the highest level of their training to contribute to a sustainable health system. And so this, for me, is one of the strong policy indications for the role of pharmacists in achieving the sustainable development goal, particularly as it relates to, to non-communicable conditions. And despite the fact that we have these policies in place to guide us in our work on non-communicable conditions, it's unfortunate that the global landscape is still not very encouraging. So I've highlighted a few things that come to mind when we talk about non-communicable conditions. They are still the leading cause of death. And every year, 45 million lives are lost due to non-communicable conditions. Up to 15 million of these lives are actually people living between ages 30 and 70. And that's what we call premature mortality. Beyond age 70, there are different things that could contribute to death beyond age 70. So when someone dies between age 30 and 70, we call it premature mortality, and 15 million lives, meaning that every 2 seconds, someone dies from NCDs prematurely. And that's a huge loss to families, to societies, to economies, and even to government, year in, year out. NCDs are responsible for up to 74% of deaths. So for every 10 deaths that we report at the country, that we report globally, 7 of them are due to non-communicable conditions. Apart from that, if we bring it home now to look at the situation in Africa, they are on track to become the leading cause of death within the African region, and that's particularly disturbing. I think it's also important to highlight that because of the way our health systems evolved over the years, our health systems were shaped to respond to communicable conditions, unfortunately, and we continue to see struggle, with managing non-communicable conditions. So if non-communicable conditions overtake communicable conditions, in terms of their burden in a place like Africa, it is important for us to rethink our approach to health system planning, our approach to training the health workforce, our approach to health system financing, just to be sure that we are ready to manage the cases we will have in our hands as the years go by. And incidentally, in some countries, NCDs are already causing up to 50% of reported deaths. For example, in Mauritius, Namibia, and Seychelles. So basically, we are seeing a situation where deaths from non-communicable conditions are growing quite rapidly. And by 2030, they would actually exceed the cumulative death from communicable, maternal, perinatal, and nutritional conditions all combined. And that's quite disturbing. So just to the right on this slide, I have also shared, some of the major non-communicable conditions. We describe them as the major because they are the leading cause of mortality, and the major and at the base of the image, the 5 main risk factors are also listed here. But in between, this apart from these 5 major conditions, there are several other non-communicable conditions that are not listed here, but continue to have impact on the lives of people globally. And also, we cannot discuss the progress on NCDs without taking some time to reflect on the impact of the COVID-19 pandemic. There's from every region of the world, what we have seen during COVID is the fact that people living with NCDs have been at an increased risk of severe illness or even death from COVID-19. And that has been a concern to us as a community, sort of supporting people living with NCDs to manage their conditions and get the attention of government. Apart from the fact that there's that increased risk, COVID-19 measures have affected the prevention of NCDs. We have seen people share that they have had less opportunity to exercise. People have had less opportunity to go out and shop for healthy meals. People have, lived in fear. People have lived with anxiety. More and more cases have been reported. Obviously, all these are most likely going to increase the global burden of NCDs that we would see in the coming years. And long COVID is also another issue that we are monitoring as a community. Many of them, mimic some of the symptoms that we have seen with the prominent non-communicable conditions. So we are quite concerned that the impact of COVID, is still something that is rapidly evolving and something that we all need to keep an eye on and make sure we are ready to address, in the coming years. And finally, on this slide, I've also shared with us the evidence we have on how COVID-19 has affected access to essential services for non-communicable conditions. So we see that, from things like screening and diagnosis of cancers, 40% of those services were affected due to COVID. 40% of countries reported that their screening and diagnosis services for cancers were affected. I think that's very significant. Also, appointment with specialists, nearly 50% of countries reported that their services, for NCDs, especially services for NCDs, were affected due to COVID-19. And the same applies to rehabilitation services and even screening for non-communicable conditions. And the simple implication is the fact that we may have missed the opportunity to pick some cases of NCDs at an early stage when we can react to them and nip them in the bud. Some cases that were manageable before, may have progressed into cases that would eventually lead to some form of disability because we didn't have the chance to respond to them. We didn't have the chance to treat them adequately because of COVID-19 measures. I think, again, this should form the things that would prompt our thinking as a body of pharmacists when we look at the work we have ahead of us in the coming years when it comes to non-communicable conditions. And so basically in this gap, I wanted to bring it home and share with us what we have seen as a community in the global NCD response and opportunities for pharmacists to make a change. Now, in 2020 and in 2020, we took a step back to look at, the policies we have in place for non-communicable conditions, looking at, for example, the Global NCD Action Plan, the SDGs, and some of the other policies that we have in place. We looked at the targets and we looked at the progress that we have achieved so far as a community. And we found that obviously many countries were not on track to achieve these targets. Some people had made progress in some aspects. Some countries had not even made progress at all. And so to simplify the challenges for civil society and other stakeholders, we narrowed the gaps down to 5 major areas. We noticed gap in leadership, where we have seen the failure of government to really monitor the action of the industry. Government, have also, not been as accountable as we would have loved to see, in order to tackle non-communicable conditions. We noticed a care gap, which I think is very critical to the discussion we are having today on the role of pharmacists in primary healthcare. Many of the people that responded to our survey described, challenges with access to medicines, challenges with the quality of services they are receiving, where they're receiving the services, how they're receiving the services, who's providing the services to them. Those were some of the things that stood out for us when we were analyzing the gaps in the NCD response. We also noticed an accountability gap where, we saw the need for governments to be more open in sharing their actions on NCDs and engaging more with civil society to ensure that their plans remain ambitious and focused on the goals that we're all trying to achieve as a body. And, we noticed an investment gap, which really talks about the fact that non-communicable conditions, despite their growing burden, despite the impact they have on economies and development, they continue to be neglected when we look at, financing by donors for health programs. And finally, we noticed a community engagement gap. We noticed that, compared to some other movements, the NCD movement, the people living with NCDs, have not been engaged as meaningfully as we would have loved to see, in shaping the policies that apply to them. And, all these are very important gaps that we noticed as a global civil society for non-communicable conditions. And I'd like to share that there are valid opportunities for pharmacists, for the health workforce, for policymakers to approach, the global NCD agenda and identify opportunities to take action and support the movements to achieve, many of the goals that I talked about earlier for non-communicable conditions. And just to bring it home and share more about what some tangible steps that pharmacists can take in strengthening primary healthcare, particularly for non-communicable conditions. Obviously, it is clear that for non-communicable conditions, we need a whole of government, a whole of society, and a health in all policy, in terms of the approach we will adopt, as in our response to non-communicable conditions. And I'll just break it down. The whole of government approach simply means that different sectors of government must understand how their work impacts on non-communicable conditions. For example, one of the last speaker talked about the fact that tobacco continues to be readily available in our communities. There should be a role for regulation. Regulating tobacco does not lie within the health system, does not lie within the Ministry of Health. It will probably lie within the Ministry of Commerce or the Ministry of Trade, or maybe the Ministry of maybe the legislation, within the government. So until we have a situation where every sector of government understands how their decisions or how their indecision affects the implementation of NCD policies, we will not be able to make significant progress. So basically, all sectors of government must work together to see that when they take a position in the form of a policy or a legislation, they understand the impact it has on diseases, on conditions like NCDs, and they work hard to make sure that it doesn't contribute to the burden in the society. Now, moving on to the whole of society approach. The whole of society approach simply means that everybody within the society has a critical role to play in responding to non-communicable conditions. And I think one of the easiest examples is to talk about things like how our churches and our mosques have been platforms to advocate for increased uptake of vaccination. It would be really useful if these same platforms of churches and mosques and schools and any platform where people come together to discuss and engage information, they are also vital platforms to leverage to push for prevention of non-communicable conditions. While I was still in Nigeria, I was lucky to participate in things like medical outreaches organized by churches And, some of them were opportunities to pick things like, early stage cervical cancer, early stage diabetes, early stage hypertension. So the role that different stakeholders will play in tackling non-communicable conditions cannot be overemphasized. And the whole of society approach is extremely necessary in the agenda on NCDs. Now, health in all policies, it's very related to what I said earlier about the whole of government approach. We must understand that our policies have implication. They either promote health or they contribute to health, to health, to sickness, to illnesses, to diseases. So we must also understand that when we are taking a position in the form of a health policy, we must understand the need for coherence. If the government is looking to tackle tobacco use among young children, we should have a position with marketing that would not be counterproductive, with respect to that policy position. When we put policies in place, we must understand how they impact on our immediate goals as a community, and that's very critical for non-communicable conditions in particular. Now, I haven't explained, what the whole of government, whole of society, health in all policies approach means. What can pharmacists really do? I was really pleased to listen to the speakers that spoke earlier, for example, on vaccination and, and also on engaging with different disease conditions, but particularly for non-communicable conditions. Pharmacists are extremely well placed to play a critical role. And without their influence, we may not be able to achieve, the goals we would like to achieve for non-communicable conditions. Obviously, I will start off by mentioning the need to amplify the needs and the views of people living with NCDs. As a community pharmacist, as a hospital pharmacist, the service users most likely spend more time with you because you take your time to explain to them their medication, the timing, maybe some side effects they can expect. You take your time to explain these things to them. You build rapport, you build trust. They share one or two things with you. And these are the feedback that we need to take back to policymakers. When we get back to the policy meetings that we attend as pharmacists, for health system shaping, for health program shaping, the onus lies on us as pharmacists to reflect back the views of people living with NCDs. There's nothing wrong in saying for every 10 patients that comes into my consultation room, only 5 of them, are covered by health insurance. The other 5 pay out of pocket. For every 5 patients that comes to my pharmacy, only 4 of them can afford all their medications. The others ration. For every 5 patients that uses insulin in my pharmacy, only 5 of them can comply with the recommended doses. These are very important feedback that we have the opportunity to share in policy meetings, and it's a wonderful way to amplify the views, the needs, the challenges of people living with NCDs, with a view to ensure better care for them. We can also lead and support different multisectoral partnerships on NCDs at any level. Pharmacists are recognized globally, regionally, and nationally. We can organize roundtables. We can bring different stakeholders together. We can invite our partners in health, doctors, pharmacists, nurses, physiotherapists, and discuss with them, what are the best practices you are seeing for non-communicable conditions? How can we do more? We can engage with different sectors of the government. We have that legitimacy as a group of people, to engage different partners to respond to NCDs. I believe we have a strong platform that we can leverage at different levels of government to engage and, and ask for more action on non-communicable conditions. For NCDs also, now moving to the third point, for NCDs, there's need for integrated people-centered care. Unfortunately, NCDs often exist as comorbidities. So, for someone who has diabetes, there's an increased risk of hypertension and vice versa. It's very, and this has impact on the quality of life of patients. And so we advocate for what we call integrated, people-centered care, care that understands the needs of the users and is responsive and acceptable and is readily available to them at the point where, is most convenient for them to receive it. So we can also call for this approach to delivering healthcare to make sure that health services are people-centered, health services understand the needs of people. For example, if I look at the situation back in Nigeria, you could navigate a health system for hours just to get treatment for diabetes. You would go in the morning, you start from the registration point up to the outpatient unit, up to the pharmacist, or from there you go to the laboratory. And sometimes you have to repeat, the same information as you move from point to point. We can have integrated systems where once an information is provided, it is synchronized and available to everybody that would serve that patient in a way that is less stressful to them. We should have a flow that supports patients to move through health system in a stressless way. So those are some of the opportunities that we have that we can highlight, while we are looking at how to improve the quality of primary health care. We should prioritize integrated people-centered care that looks at the holistic need of patients and seeks to address them in the most effective and sustainable ways possible. And we must recognize that our users are our partners. They're the reason why we're in business anyway. So we should recognize service users as co-producers of health solutions. We should recognize their role and give them an opportunity to share, based on their experience, what they think is most useful, to help them through their journey within the health system. Pharmacists can also seek and support partnerships to address the gaps in access to affordable and quality NCDs medicines. The challenge of access to medicines is a growing challenge, is a continuous challenge. And for me, it's very frustrating because within the pharmacy circle, we have the producers, we have the industry, we have the regulators, and we have those of us who dispense it. I think we could also do some work to look at, in a constructive way, how as a community, pharmacists can rise up to develop a framework that would ensure access to medicines. If you're a pharmacist and you don't have anything to dispense, like it has been mentioned earlier, there's nothing, your work is cut short, unfortunately. So there's a role for us to put a spotlight on the gaps in access to medicines and really call together our colleagues, particularly for NCDs, because it continues to be a reason why people die every year because of, there's limited funding for NCD medicines compared to those for communicable conditions. So there's really an opportunity for us to come together as a community and say, what can we really do to tackle this access to medicines challenge, as a body? Now, to move on quickly, we should also look at our competencies and skills as a group and understand how best to improve them. Over the past few years, we have seen the role of digital health, we have seen the role of telemedicine. How are we as a group making sure that we are ready to leverage all these platforms to reach more people, to provide quality care, to become more innovative in the work we do? Our training, our development programs should take into consideration the rapidly evolving landscape, when it comes to the global health system, and we should look for opportunities to leverage innovation to scale up access to our services and improve our relevance within the health system. And the last point is related to that as well. We must prioritize in developing ourselves as a workforce. I know that back in Nigeria, we had some post-graduation trainings that sort of kept us up to date in terms of, knowing what to do for different conditions. But, I'm not sure if there's strong regulation around them all over Africa. And these are things we need to know, particularly, like I said, as the need within the health system is rapidly changing. We didn't know about COVID-19, a few years before 2020, and that has really changed the dynamic of the way health systems are. So, in response to the limited resources we have, we need to keep ourselves up to date and continue to evolve in our practices to be sure that our role as pharmacists working in the primary health care setting to address NCDs is relevant year in, year out. So that's the end of my presentation. I've rushed through it. I'm sorry. I know that's a lot of information, but I'll pause now to take any questions or comments that anyone might have. Thank you so much for listening.
Thank you so much, Tolu. A round of applause to her for giving us that very concise presentation on how pharmacists can get involved in the fight against NCDs. So I cannot see any raised hands. Let's see. Oh, there's, I do not know your name, Health and Music with, let me see if I can read that. Please just go ahead and unmute and ask your question.
Hello, good afternoon. Yes. Sorry,
yes.
I tried changing my name. My name is Dr. Oge, it's the name of my YouTube channel. I want to thank all the panelists who have spoken. Very enlightening topics. Very, very important. I'm a general practitioner. I did my medical school training in Nigeria, and I'm currently working in the UK. And coming out here really exposed me to the multidisciplinary approach to primary care, which is quite different to what applies in Nigeria. And I was really nodding all through the whole presentations. And what I noticed here, and which I think really needs to be made available in most African countries for those who are not yet using that system, is a system of making everybody know their roles, know their different roles. And then there should also be legislation to protect, because one thing I find here, I work in a GP practice, like a primary healthcare center, and I am the GP, and we have pharmacists that consult. Patients come to see pharmacists mostly for medication reviews, because there's a lot of polypharmacy here, which is not as common in Nigeria. And I think it's because non-communicable diseases are still rising as against infectious diseases, which we tend to have more in the tropics. So you tend to see patients who are on like 10 medications, atorvastatin, the gliptins, maybe two or three antihypertensive medications. And we found a way to make this is now the role of the pharmacist. So they come in, the pharmacist consults. How are you doing? Do you know why you're taking these medications? Have you had any side effects? Are there any sort of interactions? The pharmacist will do the blood pressure, do the weights, urine dipsticks for those who are on antihypertensives, and then they will now be the ones to organize for blood results, and they still pass it to us as the GPs. So I think it's a case of, maybe my question is there a way that the different sectors, especially the pharmacists, now know that this is their role, one, and then also the populace also need to know that everything is not at the door of the doctor. You've got the doctor, you've got the nurse practitioners. Nurse practitioners also consult and see patients. You've got clinical pharmacists who are even pharmacists who are specialized, some of them in thromboprophylaxis, some of them in maternity care. So does the populace know? And what language are we using to educate the people so that the people know that maybe if this happens, you can see your pharmacist. You do not really need to come
Dr.
to the clinic.
Keep it short. Please keep
it
short.
So that's that's just my question. Do people know their roles? Have people been educated? And what is the legal framework to protect healthcare workers, in case of litigation? Yeah, thank you.
Go ahead, Tolu.
Yeah, I'm not sure I have all the answers. It will be useful for us to have comments from the audience. But in terms of the role of multidisciplinary teams, I think you were spot on in emphasizing, sharing, for example, how it works in the setting where you are currently. To be honest, the burden of NCDs is huge, and it is going to need coordinated care from different members of the health workforce. So it's not something that doctors alone can manage. And it's really useful to see that like hands-on experience on how patients flow, they come into the system, their blood pressure is checked by the pharmacist, which is interesting. I would have imagined that would be something that maybe the nurses would lead on. But I mean, if it has worked so well in your setting, I guess, that's another way to just sort of take the work available hands-on and do the needful. That's very interesting. So it's good to see that flow from the pharmacist table to the doctors, and maybe potentially back to the table once a diagnosis has been made and a prescription has been offered. So yes, I recognize the role for more multidisciplinary teams within our countries. And what we have right now is that people work in silos. The nurses do their thing, the doctors do their thing, and there's very limited collaboration. But we need to move to a phase where, for ward rounds, we have nurses, we have pharmacists, we have doctors working together to say, this is one of our patients who is on admission, this is the situation, what can we all do to make life better for this patient, for example? And I think we need to get to that level. And of course, we would need to have the right policies in place, like you have noted. I don't think we have, I'm not very familiar with what the case is in different countries, but in Nigeria, before I left, it wasn't really the practice. Things were still done pretty much in silos, where each person, it was more like to your tent or Israel. And it would be really useful to see, how we can have policies that guide this joint collaboration among different members of the health workforce. Thank you so much for that question.
Thank you so much, Tolu. We will have more. We'll have time for discussion after our last speaker, and we can have the questions and comments in the chat also. We can go through them and see what people think and what people's experiences have been. So our next speaker is from the International Federation of Pharmacists, and she is pharmacist Shakirat A. Adeosun. She's a graduate of Obafemi Awolowo University in Ife, Osun State. She's a fellow of the West African Postgraduate College of Pharmacists and the Director of Pharmaceutical Services, Lagos, at this Lagos State at the Primary Healthcare Board. She's a certified supply chain expert who has ensured continuous access to public health and essential medicines through the implementation of a supply chain program called the Sustainable Drug Revolving Fund Scheme at the primary healthcare centers in Lagos State. She's a multiple award holder and a member of many professional bodies, and she loves reading, mentoring, and meeting new people. So I'd like to welcome you, Shakirat. Please share your presentation from your side, and over to you. So Shakirat will still be looking at the role of pharmacists in primary healthcare, but more from a global perspective, and also opportunities that pharmacists have to be more involved at primary healthcare level.
We can't hear you, ma'am.
Shakirat, we can't hear you.
You hear me now?
Yes.
Yes.
Okay, thank you. So good afternoon, everyone. My name is Pharmacist Shakirat Adeosun, and I want to first of all appreciate the organizers for having me, the AfroPHC organizers for having me here. I'm here as a speaker of the International Pharmaceutical Federation, FIP. And first, I would like to give a brief background of FIP. The International Pharmaceutical Federation is a global federation of over 130 national organizations of pharmacists and pharmaceutical scientists. Its mission is to improve global health by advancing pharmacy practice and to enable better discovery, development, access to, and safe use of safe and appropriate, cost-effective quality medicines worldwide. First, I want to appreciate the last three speakers. They have addressed most of the roles of the pharmacist in primary care. I would first start by looking at the primary health care definition as declared by the Alma Ata Declaration of 1978. And it refers to primary health care as an essential health care that is based on scientifically sound and socially acceptable methods and technology. Technology is very key there, which is accessible to all individuals and families at the cost that the community can afford to maintain at every stage of their development in the spirit of self-reliance and self-determination. After 40 years, WHO and UNICEF in 2018 redefined primary healthcare as a whole of society approach to health that aims at ensuring the highest possible level of health and well-being and their equitable distribution by focusing on people's needs as early as possible along the continuum of care. We're looking at health promotion, disease prevention, rehabilitation, palliative care, and as close as feasible to people's everyday environment.
Can you use slideshow, man?
Yes, I just realized that I wasn't using slideshow.
You can just click the button at the bottom of your screen.
Yeah.
Oh,
thank you.
Okay.
Yes.
Sorry.
So the primary healthcare pharmacists. The vision of primary health care is to obtain universal health coverage, health-related sustainable development. Universal health coverage, we mean that people would have access to primary health services when they need them, where they need them, without financial hardship. We expect that the pharmacists are critical healthcare workforce that would help to attain universal health coverage and SDG, particularly when it relates to optimizing safe, responsible, and effective use of medicines. The primary healthcare pharmacists in Nigeria work in local communities, basically one, as community pharmacists who either own or manage pharmacies, or at government-owned primary healthcare centers, which are coordinated by the state primary healthcare boards or agencies, or they are either implementing partners or pharmacists who strengthen primary healthcare space. They all work together to complement the work of the physicians, the nurses, and other health workers to provide quality health services to the community. The roles of the pharmacists in primary health care. One, the pharmacists in primary care will contribute to antibiotic stewardship to ensure rational use of antibiotics. It's either they contribute to antimicrobial stewardship or the antibiotics itself and ensure rational use of antibiotics. Again, the pharmacist alone cannot do this. It has to be a multidisciplinary approach, as it has been stated earlier. They have to work together with the physicians, with the laboratory scientists, with the nurses. In primary care, we have some people that we call the community health officers that use some standard protocols to also see the patients that come to the PHCs for care. So all together, they will be sitting together to contribute to antimicrobial stewardship. The pharmacists in primary care also participate in standard treatment schedules for priority diseases in the grassroots. For the pharmacists that work in the primary care or the community pharmacists, because they see clients, they are the first port of call. Unfortunately, they are not recognized, they are not given adequate recognition. They should be those kind of people that would capture priority diseases that people come to complain about in their localities. However, we find out that the primary healthcare pharmacists that work in the primary health centers also sit together as policymakers to capture and design standard treatment schedules. The primary healthcare pharmacists also take charge of drug information services at the primary healthcare facilities. This again is talking about those that work in government establishments. For government establishments, we have people that have different roles. You find out that you have some people called health educators, and they are the ones that go about, engage in community dialogue and tell people about what is happening, the events that if maybe there's a pandemic, they're the ones that will provide information. But when it comes to drugs, the pharmacists, the primary healthcare pharmacists will be the ones to also help to deliver this. In Lagos State, as we speak, we have over 55 pharmacists, and we're in the process of recruiting additional 50 pharmacists that would help to ensure that this kind of services is being delivered. The primary healthcare pharmacist also provides specific and most current evidence-based drug information. The primary healthcare pharmacists apply pharmacoepidemiology principles to correlate between trends in medication usage and disease outbreaks in order to inform policy and decision-making. The pharmacists, the primary healthcare pharmacists, because they are key and they are pivotal, you find out that they help to capture utilization trends and drug effects of drugs and medications that are used by clients that they serve. The primary healthcare pharmacists are also involved in pharmaceutical care being the responsible provision of drug therapy that has some definite outcomes that will help to improve the quality of life of the clients that they serve. So you find out that the primary healthcare pharmacists, both in the community and in government establishments, that's at the primary healthcare centers, continue to provide pharmaceutical care. They are also involved in supply chain and health commodity logistics management. The primary healthcare pharmacists are involved in immunization and vaccine logistics supply chain systems, as has been said earlier. In the provision of pharmaceutical care, you find out that the pharmacists, the primary healthcare pharmacists in the community, or those that are in that work with the government at the primary health centers, maximize benefits and minimize associated risks with medicines through medical interventions. When they come in contact with prescriptions, the primary healthcare pharmacist or the community pharmacist can intervene. They can call upon the physicians that have written such prescriptions for either a change or for them to, or in situations where you have adverse drug reactions or events that can be averted. They also make, the primary health care pharmacists also make best use of resources that are available when we're speaking about pharmacoeconomics. They help to either choose which is the best or most cost-effective medicines, being the economic outcome of pharmaceutical care as against the other. So it may be that the primary healthcare pharmacist may decide that, okay, this generic brand, based on the available resources that the client that has visited the particular primary health center or the community pharmacist has at that time, they would be in a position to either give them a generic brand or a branded medication, if that is what the particular attending physician has requested for. The primary healthcare pharmacists also provide professional pharmacy services such as smoking cessation, measurement of blood pressure, and chronic disease management. Unfortunately, some of these pharmacy services are not recognized even by the community that the community pharmacists provide this care for. Smoking cessation programs occur in some of our community pharmacists in Nigeria. Some of them also take blood pressure measurements of the clients that they serve, and chronic, and also document follow through chronic disease cases that occur. They also identify plan health promotion programs. For those that work in the government space, they have outreach programs, which they move around with the community health extension workers. They collaborate together and with health educators. Everybody knows their limits, but again, you can always call on this particular health worker to discuss or attend to a particular condition. or maybe it has to do with drugs, the pharmacist can then attend to them and then speak to that particular and give drug information as the case requires. These, for supply chain and health commodity logistics, you find out that this is paramount or costs more in government establishments and at the primary health level of care. You find that the primary for selection of medicines and commodities that are based on cost effectiveness, it's the primary care pharmacists that usually carry out these particular tasks. They are the ones that forecast, they procure, they manage, and ensure that you have quality assured products in the available at the primary health level of care for the clients that they serve. They also ensure that high standards of storage conditions for these medicines and efficient distribution to the last mile, either from the central stores to the primary health centers. They also ensure that when they get to the primary health centers, they don't just dump these commodities on the floor. They should ensure that they have basic minimum warehousing or conditions available at the primary level of care. The primary healthcare pharmacists also implement and work together to at both the national and state drug policies to ensure that you have national and state drug policies that are drawn up for public health programs such as family planning and reproductive health. They also are involved in malaria, HIV, and tuberculosis. For most of this, at the primary level of care in the government space, they are really involved in logistics management information system, that's LMIS. It's purely logistics management that the primary healthcare pharmacists do when it comes to this kind of service. The primary healthcare pharmacists are also involved in implementation of the Sustainable Drug Revolving Fund scheme, which is a pro-poor initiative that helps to ensure that you have availability of essential medicines, accessibility and affordability of essential medicines all year round. And this is something that is one of the key achievements of the Lagos State Primary Healthcare Board, the agency where I work with, where we've been able to ensure that we have drugs being available in all the 320 primary health centers that we have in Lagos State. The primary healthcare pharmacists also monitor the availability, the price, and the usage of this, and then they bring up consumptions and utilizations, and then they also work in strong collaboration with the medical doctors, with the nurses, with the lab, with the CHUs, so that they stock only what is needed and we don't have wastage of scarce resources. All this has to do with a high level of skills and accountability by the primary healthcare pharmacists. The primary healthcare pharmacists also provide logistics during emergencies and humanitarian responses, such as that of COVID-19. The incident command structure of the COVID-19 during the COVID-19 pandemic was such that we had the logistics and supply chain thematic area, and the pharmacists at the primary level of care were key influencers in ensuring that we had availability of all the commodities that was needed, from the PPEs to the equipments. The primary healthcare pharmacist made sure this was practically available at the local government areas and the primary healthcare centers where they serve. They also ensured this was also done for times, maybe we have cholera outbreaks, you have was during Ebola, you have Lassa fever. They always ensure that this is appropriately done, efficient logistics during these emergency situations. They also provide inventory control of medicines and commodities to ensure accurate data collection to prevent wastages and shortages. One thing was clear, I heard from the three speakers, you cannot have a situation where you can work in silos, or you can say you've done it all without collaborating with other healthcare workers. For us to be able to achieve most of the things that was achieved at the primary level of care, it was very important that we worked with even the monitoring and evaluation team, because they are the ones that collate all the data that will be showed and analyzed, and then we present to policymakers and decision makers to take the next steps or know the way to go. The primary healthcare pharmacists also supervise and provide on-the-job pharmacy training for the pharmacy technicians and other pharmacy workforce. The primary healthcare pharmacists are also involved in immunization and vaccine logistics, and they actually do this by ensuring adequate storage conditions and distribution of vaccines and cold chain equipment. In Lagos State, we have the state cold chain officer being a pharmacist, and that has also helped in vaccine accountability, in ensuring logistics of vaccines has been well documented and accurately forecasted, and they do not have wastages and shortages. And they also participate in immunization programs. The primary healthcare pharmacists participate in immunization programs both at the macro and micro levels. For those that are not state cold chain officers, they engage, and that's why I said collaboration is very key. They work with other healthcare workers at their different LGs and go around during SIAs, surveillance activities, routine immunizations, local immunization days, NIPDs, and they move together to ensure that no child they don't leave any child. All the children are attended to and properly immunized or vaccinated. The primary healthcare pharmacists also report adverse events following immunizations, which are also known as AEFIs. And they take part in line listing of suspected cases. Like I said earlier, they work together with other healthcare workers to see what is happening in the community. So they move around, they collaborate, they do house markings together to ensure that this is what is happening. We didn't leave this particular house. There's no child here that was not adequately vaccinated. Okay, this child was vaccinated, and there's a complaint that the child, there's maybe a headache, there's a child that has temperature. They actually line list and they capture all this data. This can also be done by the community pharmacists at the primary level of care if they are also engaged in immunization services.
Sorry, we are running out of time.
Yes.
If you please just summarize the slides, and we'll share the presentation with everyone later. Thank you.
Thank you. And they also work with members of they are also members of the vaccine disposal teams. Integration of pharmacy services. The primary healthcare pharmacists are not often viewed as integral members of the health team and are often overlooked. There has been called by stakeholders of the pharmaceutical profession on the need to integrate these services together. And the question is, what model are we going to adopt? And to what extent is going to be this integration? This has been questions that begs for answers. But recent integration of pharmacy services in primary healthcare includes identification of some community pharmacies as COVID-19 vaccination sites, the devolving of stable HIV clients for refill at identified community pharmacies from the primary health centers, and using some of the community pharmacies as point of care settings for malaria. They also are involved in logistics and supply chain of family planning and reproductive health commodities. The challenges faced. The agencies of government provide technical and programmatic support to states in planning and monitoring primary health services and are focused primarily on the public sector. The challenge is that they need to change their modus operandi to cover healthcare facilities in the private sector, in which the community pharmacists have been domiciled, and this would actually give them the recognition that they deserve. This has also led, because of the slow recognition, to the slow involvement of the community pharmacists in vaccination program. For National Health Insurance Scheme, you find out that because we do not have pool of community pharmacists coming together to form health maintenance organizations. We do not have community pharmacists that are primary providers. Sometimes because they don't have enough space, they do not have internet facilities, they don't have the infrastructure, they do not have the global capitalization, just like the primary care providers such as the physicians. The primary care physicians are the ones that will get the global capitalization that will be required to give. They'll be the ones that will be provided or reimbursed, and they are the physicians are also the ones that the physicians also have. They also stock drugs, which should be the purview of the community pharmacists. So when it comes to reimbursement of the community pharmacists, it becomes a challenge. This is another case where there's a big challenge for the primary care pharmacists that are involved in primary care pharmacists. Lack of policies and regulations to support and enable contributions to pharmacists and pharmacies in primary care is something that we need to look at and has been overflowed during this session. My recommendations will be that we should provide adequate remuneration for pharmacy services in primary care, and these remunerations are critical to sustainability and resilience of pharmacy services. There should be documentations. If you don't document, you have not done it, and it's important that community pharmacists continue to document anything that they do and contribute this because of the contribution that this documentation will have on health systems, and they will be prioritized for appropriate remuneration with governments. The primary healthcare pharmacist must also be capable of facilitating change through technology. Most times we find out that some of the community pharmacists are not ready to embark on anything that has to do with technology. You find out that most of the clients that visit our pharmacies, even the primary health centers, they already know what they want to do. It's all there on Google. It's all there on the internet. They would prefer a situation where they use digital platforms to speak to the pharmacists. So our pharmacists, community pharmacists especially, must be ready to embark on technology to help to provide access to medications or care. Continuous access to education and training is very, very key if we are going to be relevant in the 21st century. And the pharmacy-based vaccination is something that also has to be prioritized. This has also been overflowed. We should also have continuous professional development programs, especially with regards to polypharmacy and efforts to increase adherence to patients. The future of pharmacists in primary care. I've talked about technology, which is that pharmacists, community pharmacists, and pharmacists at the primary level of care and that work at the PHC must embrace. They should also embrace something called telemedicine to improve access to medication, thus improving universal health coverage. It's not everybody that will necessarily want to visit a particular community pharmacy that is maybe in BI, and I reside in Agege, that is thousands of kilometers away. But I love the facilities that they offer there. So why don't I go the route of telemedicine? Digitalization of community pharmacy services is also very key, and it works very closely with telemedicine. The primary healthcare pharmacist should also be involved in disease surveillance and reporting. For those that work in government establishments, we have people called the disease notification officers, and so we know our limits. We do not delve into that tough. But those that are in community space are, because they are very close to the grassroots, if anything happens in a particular community, it's very easy for them to easily identify that particular outbreak and report as such. So there has to be a handshake. There must be recognition given to the community pharmacist to let them know that, okay, I have seen something, we can report either through the primary healthcare centers, and then it's at the disease notification. Again, the primary healthcare pharmacist should be involved and ensure that in the nearest future, we are involved in administration of vaccines and provision of immunization services. This will also help to improve coverage. It doesn't have to, it shouldn't be limited to COVID-19. It's another way of also helping to scale up family planning services if the community pharmacists are involved in this particular service. By way of conclusion, despite the vital roles that the primary care pharmacists play in maintaining and promoting public health, there has been very, very poor recognition by the government across the region. As primary care pharmacists, they assert their roles in provision of primary care services, and there is need for intersectoral, not necessarily limited to health. It could be education, even the community that we serve, and interdisciplinary collaboration to improve access to universal health coverage. Thank you very much. My references. Thank you.
Thank you so much, Pharmacist Shakirat, for that very elaborate presentation covering covering the areas that pharmacists can get involved in. Hello? I think there's a problem with your connection. I don't know if you can hear me or mic, or I think it's my connection. Hello, can everyone hear me? So thank you so much for that elaborate presentation.
Yes, we can hear you.
Oh, thank you. So we can move on to questions. I think we had seen some questions in the chat. And
I can hear you clearly. Yeah, I can hear you clearly.
Thank you. So any of the speakers, please feel free to unmute and take the questions. So there was a question on the issue of having counterfeit drugs, and that data shows that 40% of the burden of having counterfeit drugs within the system is actually coming from Africa. And the question is, why does this happen? Why do we have so many counterfeit drugs within the system, and what can we do about it? Any of the speakers are free to unmute and comment.
Okay, thank you very much. My name is Dr. Kanem. I would like to quickly say something about that. Across Africa, one of the challenges that we have is with regards to the efficiency in our regulatory system, with regards to the regulations on importation, distribution, sales, and manufacture of pharmaceuticals. In Nigeria, we have the National Agency for Food and Drug Administration and Control, NAFDAC, that has tried to make, improve or strengthen surveillance on imported drugs and those manufactured within. Unfortunately, as we know, even the agency has some challenge to regards to personnel, with regards to staffing, and that's a significant issue with that. And then again, in some other climes, that's in the West and other high-income countries, the use of technology, to monitor the end-to-end distribution of medicines in the country is helping them achieve much more. In Africa, we've really utilized technology. For example, some persons have proposed in the past that there's a way we can, with technology, we tried that in NAFDAC with the use of TrueScan, and with technology, we can monitor right from the manufacturers to the final consumer. We ensure that consumers only pay for medication or only take medication that are genuine. We had what we call the mobile authentication serial number, which is a code on every pharmaceutical product. So you scratch the code and then text the number on that code to a particular number. And if it tells you that, okay, it is authentic, you go ahead and take it. If it's not, then you should, decline taking that medication. Unfortunately, that worked for about some years in the past, but unfortunately, recently, we've not really seen that working in many parts of Africa. I think we need to strengthen our regulatory framework, and as much as possible, we need to bring in technology. We need to deploy technology in making sure that we monitor end-to-end distribution of medication from when it's imported or where it's manufactured to where it gets to the final consumer. We need to strengthen surveillance within that system. I think that's one way we can actually strengthen, reduce the proliferation of fake and substandard medicines in Africa. Thank you.
Thank you so much, Ekanem, for that. There's another question here from Malik Abdul, who says, since most countries are now shifting from the BSc pharmacy to PharmD, is there any effort to look at the job description for PharmDs using their skill sets at the primary healthcare level? And if this should be done, what are the legal frameworks and experiences from other countries? So here, any of the speakers or any of the people in the room, please feel free to raise your hand or unmute and share your experience.
Thank you. Can I speak?
Yes, go ahead.
Thank you. So for PharmD, it's a clinical certification. You know, it's still a first degree, but then for PharmD, it means that you are a clinical pharmacist. So apart from being a pharmacist, being a drug expert, you can now apply that in clinical situations. While they will find more relevance once all this maybe professional qualifications and certifications have been maybe embraced and have been approved by government, they will find more maybe job satisfaction, quote and unquote, at the secondary and tertiary facilities, where they can go on ward rounds. They can actually take part in therapeutic drug monitoring. They can take part in clinical ward rounds, ground rounds. They can take part in medication reviews. You know, at the primary level of care, it's not that as if they cannot take part in medication reviews, but then we do not admit, so they may not have that total kind of job satisfaction as if like they would have found if they were working at the secondary or tertiary level of care.
Thank you very much.
May I also add to the last speakers, there was a question that was raised about counterfeit and fake drugs. You will find out that in most countries, like Nigeria, I can speak for Nigeria, government has enacted laws that is targeted at reducing counterfeit and fake drugs. Implementation is the problem. Implementation is the problem. I can also tell you for free that we also have task force that is a combination of the Pharmacists Council of Nigeria, the Federal Ministry of, the State Ministry of Health, that go around to all the, and Pharmaceutical Society, whichever states that you find yourself, maybe Lagos State branch, they go around and try to ensure that they do not find counterfeit or fake drugs or a particular outlet that is not regulated by council. But the problem is staffing, funding is a big problem. Policies, there was a time when I know that for some years now, we've been going about saying that we want to regulate and stop open drug markets. Open drug market is something that the Pharmaceutical Society of Nigeria, the Pharmacists Council have been advocating against. But then, despite the fact that they've been doing this, they put a date. They will put a date that this year they're going to stop it, next year they're going to stop it. But again, like I said, implementation becomes a big problem. So implementation of this policies, until government takes ownership, they take the driver's seat, we'll continue to have all the.
Hello, sorry, I think we've lost you. Hello?
Oh, I said, can you hear me now? Can you hear me now? Okay.
Yes.
I was saying that government needs to take the driver's seat. Government needs to take ownership and ensure that they don't just pay lip service. We find that there's some people that don't have any business with drugs in that space, and they have a lot of funding, a lot of support. As against the pharmacists, that again is another big challenge that we have. So until these people are kept and they know their limits, they are made to know that this is the kind of drugs that you can work with, that these are the kind of drugs that you can dispense, then we'll continue to have all these kind of problems that we
Thank you. Thank you so much for those comments. You have really spanned and a whole range of the challenges that we are having, from governance to lack of HRH. I had seen David had raised his hand.
Yes, Mercy.
Go ahead.
So, my contribution is on the two, but I try as much as possible to be very brief. Some of the drivers to influx of substandard, falsified, and fake medicines are inherent in terms of our economic status. What would be the incentive for David as a pharmacist to stock counterfeit medicines? Somebody would be posing with a medicine that is actually a fake of an original that you know, of a legitimate medicine. But because you are getting it at a cheaper price and you want to cash in on the markups, then you'd be more inclined to stock that medicine. Because the ultimate driver for you is how much profit can I make out of this? I'm not saying that pharmacists are doing this, but every other dealer who is in the marketplace that is doing this is contributing because of that incentive. Then the other bit that comes into play for the common public, because when we look at it from a primary healthcare perspective, the question is what is the impact to the patients who are consuming these medicines? Somebody deep down in the rural communities probably doesn't have the finances to buy medicine from a legitimate medicine store, that is a drugstore. So instead of going to a pharmacy store where they'll get the medicines that they need, they look at alternative mechanisms. And that is where the regulation has been mentioned by Emmanuel and Addison is coming in. The regulation is not there, and therefore the black market is infiltrating the systems. And that is why even when you walk in the Nairobi streets, you'll see somebody selling deworming tablets even in vehicles. Is it legitimate for them to be selling them? Not really, but they're doing it because we have a failure in enforcement of the laws and the regulations. Nobody is cognizant of, actually nobody is concerned about what really is happening. And I think the most critical bit for us as pharmacists and stakeholders in the healthcare space to tackle the aspect of substandard falsified medicines, we need to look at it from a multi-sectoral engagement. What are the drivers? The financial and the economic imperatives. Are we going to address this so that people are able to afford their medications? Two, from a government policy and regulatory perspective, are we going to ensure that we have the regulations in place and we are actually enforcing them? Currently, the Pharmacy and Poisons Boards in Kenya says there should not be a pharmacy that is within 200-meter radius from the next pharmacy. But I know even in a single apartment, we have 3 pharmacies on different corners of the same building. So are we really enforcing what we are looking at? At the end of the day, everybody will be crowding for the same market, and it's going to affect access to the quality medicine that we're needing, and therefore people are looking to alternative measures. The other aspect that Emmanuel mentioned on the integration of supply chain is a critical bit. Because some of the times, the legitimate supply chain systems are actually broken, and they're not able to deliver on medicines. I go to a hospital, government hospital, or even in the pharmacies, and I'm not able to get the medicine that was prescribed for me. So what would be my option? And David on the other side is telling me, I have that medicine that you need. As a patient who needs to get well, you'll take the medicine that has been presented to you. But it's not that you wanted to buy the fake one. The supply chain system for the legitimate pipeline is failed, and therefore you have to look for alternative mechanisms. So that is another thing that for us as pharmacists who are working in the supply chain component, are we able to ensure we have a reliable supply chain that will ensure patients have access to the medicine when and where they need them, that they don't have to look for alternative mechanisms of sourcing for that medicine, because when they do, they're going to have an influx of the very substandard and falsified medicine that we are against. Then that transition that you mentioned from transition from B-Pharm, Bachelor of Science, Pharmacy, or even to PharmD, it's clinical, as you've mentioned, yes, that is the key bit. So we are going clinical in that aspect. So in that case, then the focus would be what clinical services do we need for pharmacies? Personally, even in Kenya, we are looking at it at a discussion level from the Pharmacy and Poisons Board and different stakeholders, Pharmaceutical Society of Kenya. Yes, we are open to that move towards PharmD, but it should not be for every individual. Our needs are not only clinical. Our needs are coming from supply chain, as we're talking about falsified and substandard. Our needs are in regulatory affairs. We're looking at regulatory harmonization, because even without the harmonization, that's why we have products that are, let's say, for example, Kenya and Uganda, we share a border. Probably the regulation in Uganda is not as strong and as stringent as would be required, and therefore substandard medicines will be infiltrating the Kenyan market from that kind of territory. So how do we ensure we have an integrated system? We need people in regulatory affairs. So at the end of the day, the question would not be, do we all move to PharmD? Not really. Our approach we should have PharmD, yes, but it should have Bachelor of Pharmacy as a program that is looking at what are the other areas that we need to intervene as pharmacists to ensure that we are addressing the public healthcare needs of our communities. And once we drive that need, then even in the curriculum review, as we're talking about it, it will be a curriculum that is informed by what we need, not a curriculum that is informed by our inclination to adopt everything Western. Because at the current moment, even from the discussion, everybody's about PharmD because Canada has adopted the PharmD program, USA is adopting PharmD program. But is it the PharmD program that we need in Africa? We still have global health challenges. People are dying from cholera in the villages. A PharmD doesn't solve that, but we need a public health pharmacist who is able to reach out to the community and address their needs. And I think that is the approach we need to be looking at. Let's not do things because they're addressing what the developed countries are doing. Yes, they're doing it, it's good, yes, for them because it's addressing their needs. In an African context, what are our problems? Are we addressing our problems? Then let's design solutions that are going to help address these problems. And even in capacity building, let's train people for the skills they need to intervene and serve their patients. I think that would be the best approach for us. Thank you.
Thank you so much, David, for those comments. I don't know if, Joseph, you're able to unmute and make a few comments because you have commented on a number of things. And if you're able to unmute and just voice them out, that would be amazing because I'll not be able to read them all out. You're talking about the issue of task shifting and how it should be, we should do it carefully, even as we are building the PHC team. Joseph, are you able to unmute? I don't think he's able to unmute. So there are a lot of comments in the chat, but I will not be able to read out all of them. And most of them are addressing challenges, opportunities that we see for pharmacists in the PHC system and what we can actually do to make sure that pharmacists are integrated into the system. So I'm just going to read this one last comment from Joseph, that unless they are trained and monitored, no cadre or professional should do what the medical does, purely for quality and safe care delivery to the patient. Task shifting is important and useful, but it must be structured, monitored, and regularly evaluated for patient safety's sake. That is the way to appreciate the contribution of every health team member. Even dispensing requires skills that must be learned, and talk more of making a diagnostic, mapping out the treatment of the diagnosis. I think that's a nice comment to really wrap up what is going on in the space right now in terms of trying to see how best do we integrate pharmacy and all the other members of the PHC team. I'd like to apologize today because of time. We will not have our usual breakout session, but I want to thank you, all of you, for joining us today. I don't know, Prof. Shabir, do you have any comments? So I'd like to thank you all for joining us for this very important discussion around the value of the pharmacist in African PHC. I hope you have all carried a lot from this discussion. The presentation and the presentations from all the speakers and also the recording of this will be available later on the AfroPHC website. So later on in the week, you can check to see, for those who missed part of the presentations, you can check and actually follow the presentations from the website. I'd like to thank the AfroPHC coordinating team. I'd like to thank all our speakers for making the time to be with us today. And I'd like to thank all the participants for all your wonderful comments. And the comments and the presentations will also go into, someone had mentioned the issue of a policy document. There's a policy document in development for building the primary healthcare team in Africa. And so they will be included there. And with that, I'd like to close our session today and wish you a wonderful evening. Thank you, everyone.
Thank you for the opportunity.
Thank you for having
the opportunity, and thank you for the wonderful session, everyone.
Very good.
Bye.
Thank you.
Thank you, everyone. Have a lovely evening.
Bye-bye.
Hi, everybody. It seems that there's been a technical problem, but thank you all very much for all your attendance, and to all our guests, thank you very much. It's been a great event. We'll see you all, and the recordings will be on the website. Please have a look at it. And we hopefully get the presentations and put them there as well. Bye-bye, everyone.